And
in order.
Yeah, in order. Let's just switch.
and then I'm the second one.
Yeah. We're going to play Duck, Duck, Goose.
So I'll
again.
go here.
There we go.
So have we got everybody? Yes, we've got everybody. Yes. Shall we start?
Hopefully this.
Yeah.
Okay, good morning and a very warm welcome today too. So we've got a fantastic lineup of talks on neuroimaging and other biomarkers and plenty of time for, I hope, what will be a really stimulating discussion afterwards. So I'm Natalie Ryan, I'm a neurologist at UCL and I work with the Diane team at WashU on autosomal dominant Alzheimer's disease. I'm one of your co-chairs and I'd like to introduce my other co-chair, Bo.
Thank you so much. It's really great to be here. My name is Bo Ansis, and I just wanted to thank the organizers and everybody. We're going to have a great second day, and as you heard, our first speaker on this session is Agnes Perez-Millan, who's going to be talking about cortical asymmetry index and autosomal dominant Alzheimer's disease findings from the Clinic Barcelona and the Diane cohorts.
Here we are presenting together the results of Clinic Barcelona and Diane Ops cohort. And no disclosures. And as introduction, we know that Alzheimer's disease leads to a progressive cortical atrophy, typically described on visual inspection as symmetrical. However, recent studies have described the presence of asymmetric patterns in individuals with AD, identified using advanced neuroimage techniques. For example, the paper of Lloyd et al. 2019, where they studied the asymmetry in thalamic subnuclei, they have found that in the ventral nuclear region, they present differences between the right and the left hemisphere in MCI and Alzheimer's disease. Other studies of Roe et al., where they focused in the lifespan and mainly in healthy controls, they found first that the cortical asymmetry in healthy controls grows in childhood and peaks in the early adulthood. So we have a progression of the brain asymmetry during all our life. And in the work of Roe et al. Of 2021, they study the comparison of healthy controls and Alzheimer's disease patients. So they found that the brain asymmetry is accelerated in patients with AD compared to healthy controls. So in the left figure, it can be seen that some of the regions are significant and some of them no. But in the yellow line, it's the healthy controls, and the green line, it's the Alzheimer's disease patients. So you can see different trajectories. We have 4 follow-ups, so the brain asymmetry progressed differently in the both groups. And it was mainly focused in the frontal and anterior temporal cortex. This year, in our group, we present the work Perez-Millan et al. 2025, where we develop a cortical asymmetry index, the one it was presented last year. And in that work, we focused to develop the index which allow us to differentiate differences between hemispheres with only one measure, and we study healthy controls, Alzheimer's disease, patients, and frontotemporal dementia, FTD. And there we can see that the lowest measure of the index is that you have the brain more symmetric, so it will be the healthy controls. And the highest value of the cortical asymmetry index, it means that you have more asymmetric brain, so you have the FTD. And in the middle, you can have the Alzheimer's disease. And we demonstrate the capacity of this marker to estimate brain asymmetry and discriminate between all of the groups. Also, in that work, we don't have so much data for the second visit, a follow-up after 2 years, but it was enough to see that the FTD participants after 2 years have increased their brain asymmetry, and the Alzheimer's disease, we don't find any significant differences, but it can be see a tendency of this increase. But here we are not talking to sporadic Alzheimer's disease. We are here to talk about autosomal and dominant Alzheimer's disease. But we have to say that most research in the field has focused in sporadic AD. And there is a lack of studies investigating brain asymmetry in AD. And the ADAD population offers the opportunity to evaluate biomarkers from the presymptomatic stage until the phase of dementia, and it could be the key to understand the brain asymmetry phenomena and how it progressed in the AD continuum. And I have to say that, again, it will be a work of sporadic AD. As I have mentioned, it has not been done anything in ADAD that we know. So here, a work of Wechinger et al. 2016, that it was ADNI. It has seen that brain asymmetry may precede the onset of symptoms, suggesting that this marker could have value in monitoring disease progression. So we have the green line, that is the healthy controls, then you have the stable MCI, then the converted MCI, and finally the AD patients in the red line. So you can see the progression of them. So for that, in this study, we have 3 objectives. The first one is to investigate brain asymmetry using the cortical asymmetry index, the CAI, in ADAD to explore its potential as an early biomarker for AD. The second is to explore the effect of a POE genotype on brain asymmetry using the cortical asymmetry index in ADAD. And finally, the third one, to assess brain asymmetry longitudinally and evaluate its correlation with global cognition measures as MMCI scores, neurodegeneration markers with NFL, CSF and plasma, and to determine if CAI can track the AD progression. So to do that, we have 2 cohorts. The first cohort is the Clinic Barcelona cohort that I will explain a little bit, but if you want to know more details of the cohort and what we have and what we are going to have and so on, you can visit the poster number 22 of my colleague, Dr. Bea Bosch, that it will explain. But for this study, we have 19 healthy controls, 22 symptomatic mutation carriers, and 19 symptomatic mutation carriers. So it's a small cohort. So for that reason, we have like a replication cohort or also the unique cohort in some analysis that is DSAD-ADAD. In this case, we have 215 healthy controls, 2,034 asymptomatic mutation carriers, and 115 symptomatic mutation carriers. These 115 symptomatic mutation carriers allow us to subdivide this group in 2. So we will call symptomatic mutation carriers MCI the ones that have CDR equal 0.5, and symptomatic mutation carriers AD the ones who have equal 1, the CDR, or higher. I want to mention some differences between the 2 cohorts. It's true that we will focus to try to replicate, but there are some unique differences in both cohorts that can explain some results that it was not replicated. The first one is the estimated years of onset. If you look, the asymptomatic mutation carriers of the Clinic Barcelona cohort, it's minus 9.4, but in the DSAD-ADAD we have minus 14.1, so they are more far away than the cohort of here from Barcelona. And in the similar way, but in the other one, the symptomatic mutation carriers in the Barcelona cohort, we have 2 years, and in the symptomatic mutation carriers of the DSAD-ADAD are 0.5, so are closer to that moment of conversion. And also we have some differences in the mutations. In the Clinic Barcelona cohort is mainly present in 1, and also we have some APP, but in the DSAD-ADAD we have the 3 genes present in 1, 2, and APP. So first of all, for be able to estimate the index, we need the cortical thickness obtained with free surfer and the structural MRI. And this index, it works as you need to choose probability distributions, and then it measures the entropy of them, so to know the differences, and obtain only one number. So we will have one distribution of probability distribution, it will be the left hemisphere, and the other one the right hemisphere, and we will obtain the index. This index has been published this year, as I mentioned, in European Radiology, and also it's available in GitHub, and it's used in Python language. And to structure the methods and also the results, I will divide in 2 blocks. The first one, the cross-sectional analysis, that in these ones, it will be some of them with the 2 cohorts and some of them only 1 cohort, and then the longitudinal analysis that it's only with the DSAD-ADAD cohort. So at cross-sectional level, at the baseline, we measure the differences between the cortical symmetry index between the clinical groups in both cohorts, and also in both cohorts, we estimate the correlations between the cortical cortical asymmetry index and the mini-mental score, the NFL levels, and also the EU. And then only with the Diane ops, because with our cohort we don't have enough sample to do, we study the APOE genotype differences regarding the cortical asymmetry index. At longitudinal level, again, we don't have enough data to do longitudinal analysis, so we only have Diane ops cohort, and we study the progression according to EYO with generalized additive models. So first of all, the results, we have mutation carriers to start. When I'm referring to mutation carriers, that sometimes it can be confused because then I will start talking about APOE. Always in this talk, I'm referring that studying asymptomatic mutation carriers and symptomatic mutation carriers together. They show greater cortical asymmetry than healthy controls, and we only have significant differences in the Clinic Barcelona cohort. And also, in that case, yes, in both cohorts, the mutation carriers have higher Chi, present with higher NFL levels. Advanced AO, for me it means, I suppose that for more people, in that way that you are more on the right of the x-axis, so positive and negative, and lower mini-mental scores. Then we subdivide the mutation carriers to study separately the asymptomatic mutation carriers and the symptomatic mutation carriers. And we can see that the healthy controls show differences in asymptomatic mutation carriers and also with symptomatic mutation carriers. And the symptomatic mutation carriers replicate the same associations that it has presented with the mutation carriers altogether. For the Diane ops cohort, we replicate the healthy control versus symptomatic mutation carriers differences, but not the healthy controls versus the symptomatic mutation carriers. And here it's the reason why I have mentioned in the methods when I explain the core the differences of EYO. So we think that it could be an explanation as the asymptomatic mutation carriers of the Clinic Barcelona cohort are more closer to the conversion than the Diane ops, and the symptomatic mutation carriers are have more years after the conversion. And in the Diane ops, as I mentioned, we can divide the symptomatic mutation carriers in two groups. So then we analyzed again the possible differences, and we have that the healthy controls and the symptomatic mutation carriers replicate the results with the symptomatic mutation AD group. And then we find differences between symptomatic mutation MCI versus the symptomatic mutation carriers AD. And in this case, we only have significant differences for the association with symptomatic mutation carriers AD with EYO. So then, moving to the APOE genotype results, we focus with mutation carriers. So we analyze all the symptomatic mutation carriers and symptomatic mutation carriers together, and we find that the APOE 3-3 genotype have higher Chi, so it measures that have greater cortical asymmetry, respect all the possible APOE genotype that we have available data. That, for example, it's not the 2-2. And also, it was not significant, but the APOE 3-4, it can be seen that also have higher cortical asymmetry, although it's not significant, as I have mentioned. And here, it's all the symptomatic mutation carriers and them together. So then we want to study if we can find differences between the asymptomatic mutation carriers and the symptomatic mutation carriers. And the only genotype that allows that is the APOE 3-3, where we find this significant difference. And the healthy controls do not present any significant difference in any of the APOE genotypes. And finally, the longitudinal results, we have that mutation carriers show an increase in cortical asymmetry over time compared to the healthy controls. Then when we subdivide the mutation carriers in the two groups, these significant differences it keeps in the symptomatic mutation carriers that increase their cortical asymmetry over the time compared to healthy controls. And finally, when we subdivide the MCI, this significant difference it keeps in the symptomatic mutation carriers AD, that it's like the pink link that it's the high increase. So to conclude, the mutation carriers, both the symptomatic mutation carriers and asymptomatic mutation carriers have greater brain asymmetry compared to healthy controls, in some cases significant and in others at visual level. APOE 3-3 individuals show greater brain asymmetry than APOE genotype. In mutation carriers and the symptomatic mutation carriers correlate with measures of disease severity and shows an increase in asymmetry over time. And to sum up, the brain asymmetry is a potential biomarker for monitoring and tracking disease-related AD neuroanatomical changes. And before ending, thank you so much to the Alzheimer's group of Hospital Clínic de Barcelona, all the co-authors of the work that are listed, and special thanks to Dr. Raquel Sánchez del Valle for their support, and also Dr. Bea Bosch and Dr. Neus Falgas that help a lot in developing this group. And obviously, and I'm very thankful to Diane Ops to allow us to have their record and replicate the results, and also all the co-authors of the study that give us very interesting and helpful feedback of the study. Thank you so much.
Questions at the end. Thank you very much. I'd now like to introduce Lajos Chinchik from Queen's University in Belfast.
Can you hear me? Yeah, okay. Hello, everyone. I'm honored to be here second time, and again, talk about the importance of retinal and choroidal changes in Down syndrome and research into that. And I hope that by the end of my talk, you will realize that the eye is more important than the brain, and we don't need neurologists anymore. So, because the eye is the window to the brain, the retina in the eye is part of the central nervous system. It develops from the same embryological tissue, and in sporadic cases, we find that retinal changes may mirror changes in the brain. But the most attractive part of eye imaging, of course, the speed, that's much faster, and we can achieve much higher resolution in eye imaging. But what do we image? We image the back of the eye here, and what we can see here then, we can see nicely the retinal vessels. In fact, this is the only part of the body where we can see the naked blood vessels, and we can measure all sorts of different things on them. And in sporadic AD cases, we find reduced vessel caliber and reduced vascular tree complexity. Again, this is in sporadic cases. And when we generate this optical cross-section of the back of the eye across the retina using optical coherence tomography, we can nicely see the different layers of the retina and the underlying choroid, and we can also measure the thickness, pretty much like what you do on MRI. And lower retinal thickness may indicate neurodegeneration, and higher retinal thickness or increased retinal thickness may indicate inflammation, sign of inflammation. In sporadic cases, we find reduced inner retinal layer thickness, and we find reduced choroidal thickness. Now, what do we see in Down syndrome? Just to note, our cohort is mainly asymptomatic, but at the age that very close to the transition to the clinical phase. And so when we measured retinal thickness, in inner retinal thickness, we find an increase in Down syndrome compared to control instead of decrease, what's seen in sporadic AD. And when we measure the choroidal thickness, that is the underlying tissue here under the retina and feeds the outer retinal layer, we find thickening again at each point where we measured. So that was, we find this really interesting, as the opposite of what we've seen in sporadic cases. We also know from this publication that in children, this thickening is not visible. So this must be a feature of an older population. And what was also interesting for a subset of our cohort, that PET scan was available, PET amyloid, we find that there was a positive correlation between choroidal thickness and cortical amyloid load. We find this really interesting, and we think that this might indicate a sign of inflammation. And that is why the tissues thicken, and it might be potentially due to the developing AD pathology in the retina and the choroid. And we know from sporadic cases and autosomal dominant cases that it's been shown in the brain there when amyloid start accumulating, AD pathology starts, then there is a thickening, probably due to inflammation, and then you will see going into neurodegeneration when you will measure thinning. But do we know anything about AD pathology, whether AD pathology affects the retina and the choroid? The only evidence, I think, is here. Published a study conducted by Mike Raffay and Robert Risman, where they fed the patients with curcumin, a dye that binds to amyloid beta, and it fluoresces, and it's measurable with a laser scanning ophthalmoscope, and you would see these little bright spots, curcumin positive spots in the back of the eye. And indeed, they did see this regardless of APOE4 status in all of their Down syndrome cohort. So this is the only evidence from Down syndrome. I'm not aware of any study, post-mortem studies carried out in Down syndrome retinas or choroid. So we need to turn here to what we see in the sporadic cases. So in sporadic cases, a group from UCLA led by Maya Coronio find these amyloid deposits or aggregates in the retina, mainly in the inner retinal layer, and the lack of that in the controls. And another group in Amsterdam with a great eye and brain bank, they find also hyperphosphorylated tau aggregation in the retina. In fact, that correlated with Braak staging, so on the corresponding brain samples, which we found really interesting. And also this was most evident in the far peripheral retina. And what do we know about blood vessels? We know from sporadic cases, again, that amyloid also accumulates in the blood vessels of the retina. And in fact, that may cause damage measured by pericyte loss, again, in sporadic cases. And then when we looked at choroid, there are no postmortem studies, human postmortem studies on the choroid, but we do have transgenic mice models, AD transgenic mice model, when they find the presence of amyloid beta in the choroidal tissue as well. So just going back to our cohort, or Down syndrome cohort, the area where we saw the thickening, it was exclusively in layers that are vascularized. So in the inner retina, that's where the retinal vessels are in normal circumstances, and the choroid, which is a highly vascular layer. So, but what do we know about the vasculature, retinal vasculature in Down syndrome? Again, the answer is basically nothing. That was a paper published in 1980, I think. That was the first report on showing that there are supernumerary vessels in the retina crossing the optic disc margin in Down syndrome compared to control. But that's really all. So we went to turn to a more sophisticated method. We used novel imaging method called ultraviolet imaging that captures the entire retina, not only the central bits of the retina. We used deep learning algorithms to segment out the retinal vascular tree. And when we looked at the complexity of retinal vascular tree in the central retina, we find an increase in complexity, which is not surprising because of the supernumerary vessels that's been described already. But when we extended the analysis to the periphery, we find the opposite. There was a lower vascular complexity, lower vascular tree, which may indicate neurovascular degeneration in the peripheral retina. And in fact, this aligns with what we've seen in sporadic AD cases. So Then we looked at the vessel caliber around the optic disc, and we've measured wider arterioles and venules in Down syndrome, which we find interesting, just considering the supernumerary vessels and also wider vessels than the control. And so then what we did is measured how the vessel thins along the vessel part. The faster thinning vessels may again indicate neurodegeneration in the peripheral retina. And so we did, and we measured the width of the vessels along the vessel path, and then we plotted it, and we fitted a line, and the steeper the slope is, the faster the vessel thins. And this is what we find in Down syndrome, faster thinning vessels, again, maybe a sign of peripheral degeneration, but could be also driven by the wider vessels in the central retina. We don't know at this stage. And in fact, this again aligns with what we've seen in sporadic AD cases before. And then knowing that in sporadic cases, amyloid accumulates in the blood vessel wall, we were also interested if we can see any vascular damage in the back of the eye to the retinal blood vessels. And in the retina, it's really easy to detect these changes, not only hemorrhages, which is more obvious damage, but also little microaneurysms, which obviously you probably wouldn't detect in the brain. And so we looked at these signs, and what we find is there was 36.4% of the eye in Down syndrome had these microvascular abnormalities in the back of the eye, compared to controls that only had 8.8%. And I think it's particularly interesting. Yesterday we had a good discussion about the ARIA. Would this be the way in the future to stratify patients for antibody trials? And so just to conclude, we definitely see differences between control and Down syndrome, but whether that's driven by AD pathology, that yet to be confirmed. And for that, to take the field further, we definitely need longitudinal studies where we have eye imaging, multimodal eye imaging with brain imaging, so we can correlate changes, or at least cross-sectional studies looking at a wider age range with multimodal imaging. And most importantly, post-mortem studies, because as I said, we're not aware of any post-mortem studies in the retina in Down syndrome that in relation to Alzheimer's disease. And the good news is that we already finalizing a plan to start doing a longitudinal study, and we just need to secure funding, and this is already underway in Belfast. We're conducting a REVEAL study. If you scan that, you can see details. And we are also trying to secure some post-mortem eye samples from Down syndrome to look at AD pathology in post-mortem samples. And thank you very much for your attention. And these are just some of the members and collaborators.
Great job, thank you. Our next speaker is Alejandra Morfillo Nieto, who is going to be talking about PSMD as a promising biomarker for early identification of white matter integrity changes in Down syndrome.
Hi, everyone. Thanks to the organizer for giving me the opportunity to share this word today. So first, I think that there is no need to say here in this audience that Down syndrome is a genetic form of Alzheimer's disease, but what is also interesting is the coexistence of cerebrovascular disease in this population. I would like to highlight these two articles from 2017. Both reported that cerebral amyloid angiopathy, CAA, is more frequent and more severe in Down syndrome compared to control or sporadic Alzheimer's disease. The first one, led by Dr. Elizabeth Head, used post-mortem data that is the only way currently to diagnose the definite CAA. For the other study, led by Drs. Maria Carmona and Mircea Balassa, using the DAD cohort data, the neuroimaging information, they also show how the CA increased with advanced stages of the Alzheimer's disease, with 40% of the individuals with dementia showing CAA. So they also show that the CA appears at younger ages and its severity increases with age. Since then, there are some more neuroimaging studies focused on these small vessel disease biomarkers in Down syndrome. For instance, we have samples from our DAD cohort and also Dr. Patrick Lao from the ADAD-DSAD study. Both shows that microbleed increase with age. Also with the perivascular spaces, we can see the age-related changes in the microinfarct and with the white matter hyperintensities. All these markers also increase across the Alzheimer's disease continuum in Down syndrome, showing the highest prevalence at the dementia stage. The recent years, there is another interesting imaging called the diffusion-weighted imaging that has been proposed to study the integrity of the white matter because it's more sensitive to detect changes in the brain that the conventional scan could miss. So here, I would like to introduce the PET width of the skeletonized mean diffusivity, which has been proposed, has been developed in 2016, and interestingly has been proposed as a small vessel disease biomarker. Basically, higher values of this metric reflect damage in the white matter. Previous studies have shown that PSND was higher in people with CADASIL, a genetic form of the small vessel disease, also in CA and in sporadic Alzheimer's disease. However, this metric has not been tested in a Down syndrome population. So here we are. We are going to characterize alteration of PSND in both sporadic and genetic form of Alzheimer's disease. The specific aims were to study the impact of demographic variable on this metric in a sample of sporadic Alzheimer's disease and Down syndrome compared to control. Second, to investigate the effect of Alzheimer's disease clinical stages on PSND and its association with Alzheimer's disease pathology. And finally, we also want to evaluate the relationship between this metric and other neuroimaging markers related to small vessel disease. To do this, we include in our study controls and Alzheimer's disease patients from the SPIN cohort and adults with Down syndrome from the DAD cohort. All the participants underwent a neurological and neuropsychological evaluation to determine the Alzheimer's disease diagnosis. Like this, we could classify the participant into cognitive stable, mild cognitive unimpaired, and AD dementia. Most of them had CSF biomarker for amyloid, phosphorylated tau, and neurofilament, and finally, of course, all them underwent a magnetic resonance imaging protocol, including, among others, a T1, a flare scan to estimate the white matter hyperintensities, a SWI to count the microbleed, and the diffusion weighting imaging to compute the PSND. In the computation of the PSND, we use a standard pipeline to pre-process the raw scan, the raw diffusion scan. So this first step is a kind of improvement of the quality of the scan, and then we apply the diffusion tensor model to obtain the mean diffusivity map. Once that we have this map, we apply the well-established script to compute the PSND developed by Bacara and colleagues. So this script takes the mean diffusivity map projected on the white matter of the white matter tract, and then the PSND is calculated as the difference between these two percentiles that we can see in the histogram. So now that we have the PSND, we are going to move to the results. So in our study, we include 143 euplate controls, 115 Alzheimer's disease patients, and 216 Down syndrome. The mean age of the Down syndrome group were 45, significantly younger compared to the controls and the sporadic Alzheimer's disease. 44% of the Down syndrome were females, a lower proportion than in the other two groups. Regarding the clinical diagnosis, 70% of the Alzheimer's disease patients had mild cognitive and impaired, and most of the Down syndrome participants were at the asymptomatic stage. Finally, we also used the A+. We wanted to classify based on the amyloid beta measured by the CSF, by the ratio of amyloid CSF, as an inclusion criteria for our Alzheimer's disease patient that had to be positive in this metric, in this biomarker. So now, when we're looking at the result, at the association between PSND and AIDS, we found a significant association with the control, also with the sporadic Alzheimer's disease, and also in the Down syndrome population. We also observed sex difference in the control and asymptomatic group, with male presenting higher values of PSND than the females, but this sex difference we didn't observe in the Down syndrome population. Regarding the Alzheimer's disease clinical stage, we found within the euploid population that the sporadic Alzheimer's disease, both mild cognitive and impaired and dementia stage, had higher PSND values than the control, and similarly, we found this result within the Down syndrome population, with the prodromal and dementia stage showing higher values than the asymptomatic one. But we couldn't even see any difference between the NCI and the dementia stages for both populations. About the association with the CSF biomarker, in the case of the ratio amyloid beta 40/40, we only find significant association in the Down syndrome population, and this was also observed in the case of the phosphorylated tau. Neurofilament was the biomarker which saw an association in the three groups. Finally, we also assessed the association with other small vessel disease biomarker. So in the case of the microbleed, only in the Down syndrome population, we found significant difference between those individuals who had one or more microbleed, presenting higher values of PSND. And in the case of the white matter hyperintensities, these associations were found across the three populations. If we focus on the association, of the association in the Alzheimer's disease sample, we can see a clear linear correlation between the PSND and the white matter hyperintensities. But if we focus in the Down syndrome group, we observe a subset of participants which already have greater values of PSND, while white matter hyperintensities were in somehow a low level of volume. So we wanted to dig more into this result, and we established two thresholds based on the group, on the control group. So values above that threshold will be considered PSND and normal, PSND plus, and we do the same with the white matter hyperintensities. If we combine both thresholds, we can see that the proportion of the individual with Down syndrome who present a normal values of PSND and not white matter hyperintensities, a lower volume, was significantly higher than those subjects without alteration in the PSND. We tested these different thresholds to ensure that the robustness of the result, and it remained consistently across the different thresholds. So, in conclusion, PSND was associated with AIDS in all the three groups. We observed that males presented higher PSND values than females in control and Alzheimer's disease. The lack of sex difference that we observed in this metric in the Down syndrome has been also observed, not found in other neuroimaging markers of the small vessel disease. The sporadic and genetic form of Alzheimer's disease presented higher PSND values compared to the controls, and within the Down syndrome population, we can see how increase the PSND across the Alzheimer's disease continuum. PSND was associated with the neurofilament protein in control as MDC and Down syndrome, which is not surprising as the neurofilament biomarker is specific of axonal loss. And finally, in Down syndromes, only in this population, individuals who present a microbleed had higher PSND. These results suggest that CAA may be an underlying etiology in this population, and the PSND was associated with white matter hyperintensities across all the three groups. In a further analysis, this last one, we suggest that alteration of the PSND may precede the emergence of white matter hyperintensities, but we are aware about the limitation of this cross-sectional study, so we are currently doing a longitudinal analysis to better clarify the temporal sequence between these two markers. So that's all. Thanks for your attention. I would like to thank to the San Pau Memory Unit, and especially to my supervisor, Alexandre Villanan. Thank you.
Thank you. And for the final talk of this session, James Kennedy's talk is going to be given by Bo Ansys on brain volume trajectories in Down syndrome and autosomal dominant Alzheimer's disease.
It's a pleasure to be here, and thank you so much for having me. I'm sorry that James is not able to be here. I'd rather be in the audience taking pictures than being upstage here, but it is really a pleasure to be here today and talking about James's work. We will be talking about brain volume trajectories in Down syndrome and autosomal dominant. Here are my disclosures. The biggest one is I wish I had more stock or equity and I was more diversified in other companies and stuff, but I don't. So let's just talk about first, you've already heard today, and also even in previous days, there are definitely comparisons or similarities and differences between Down syndrome and autosomal dominant. A number of groups, including the great group here in Barcelona, as well as us and others, have started to really look at these similarities and differences. And what you can see on the left-hand side of the figure, looking at amyloid changes, you can see that there are amyloid changes. These occur anywhere between 17 and 20 years before an individual becomes symptomatic, that EYO that you've already heard of before. In the middle figure, you can already also see these kinds of comparisons with regards to tau, and that tau soon follows amyloid. In our hands, and Matt Zammit and others have seen that this difference is about 2 years, versus in autosomal dominant, it can be anywhere between 5 to 7 years after an individual has these changes. And then more recently, and you heard from some great work that Omar was presenting, Abdulhadi was presenting yesterday, he's also looked at FDG PET, and you can see that there are 3 different groups. In the pink are Down syndrome, or green are autosomal dominant, and the yellow are our controls. You can see as we're sitting here, sorry to say, your FDG PET may be going down. No, I'm joking. But needless to say, in autosomal dominant, there is this all of a sudden almost inflection point that's occurring. And in Down syndromes, there's this gradual changes. And so what we're interested in, James was really interested in looking at, was what is the role of these MRI volumes and cortical thickness changes in autosomal dominant versus Down syndrome. And at the end, I'll try to relate this to the next session that will be coming up, and why these kinds of measures are going to be important for us, especially when we're thinking about different therapeutics with many in the room and different companies here as well. So how did we do this? We took participants with genetic AD and their familial controls. Those are individuals either from ABCDS, the Alzheimer's Biomarker Consortium for Down syndrome, or those in dominantly inherited Alzheimer's network. All participants needed to have an MRI, and most also had amyloid PET. And then both PET and MRI were processed the same way, so we've done them consistently across both of the groups, and we controlled for the same parameters to allow for cross comparisons. Then we examined the relationships between volume and this estimated years to onset, or this EYO, as well as looking at amyloid PET and centiloids. And then EYO for autosomal dominant was calculated the typical way that's been done by Diane of looking at the parental onset and then looking at the mutation average as well as actual decline of the individual. With regards to EYO, you already heard some results by Eric Rubenstein and others yesterday, as well as others that have presented. We used a set point of 52.5. There's a number of literature that's there that has shown that that is a reasonable age to pick. And then for EYO, for controls, we used it as same as the family member. For our statistics, we looked at the relationship between the intercortical volume and corrected it for normalized regional brain volumes with EYO and amyloid PET. And then we used these GAM functions that you've already heard about earlier today. So groups were normalized collectively and then separately based on their amyloid status or their membership for each of the cohorts. And then what we did specifically with Down syndrome, because we also know that there is intellectual disability and there are changes even since birth, and so we allowed for comparisons of groups with actual or adjusted or without adjusted Down syndrome developmental offsets. Then we also looked at controls that were omitted for the centiloid analysis because their amyloid values were well within the noise. And then GAM functions allowed us to compare the group differences with regards to their shape, their slope, their offset, and then when they diverged from this. And then we looked at different effects, as you can see, in autosomal dominant Down syndrome and control slopes, and their offsets were allowed to vary. We also controlled for other factors, and we've had discussions yesterday about some of these, including ApoE4 status, sex, and then use of different free surfer methods to calculate these volumes as well as thickness. And then we controlled for random effects of individual nested under family. And then we did and controlled for multiple comparisons. So what do we have in our demographics that are present? You can see at baseline and then all of the individuals, even if they had multiple time points in the all categories. What I've highlighted here is that in average, our Down syndrome individuals are a little bit older than our autosomal dominant. You also see that our autosomal dominant have a little bit younger, or EYO less or closer towards that 0 point compared to the other groups, and that the centiloid values in our autosomal dominant were a little bit higher than those seen in Down syndrome. And then in the all categories, you can see that we have a large cohort of individuals. So really, I think this is one of the largest cohorts of individuals with genetic causes of Alzheimer's disease using MRI imaging. And then at the bottom, you can see we've separated them out into the different mutation statuses that were present as well, specifically with regards to, of course, autosomal dominant Alzheimer's disease. So in our first set of results that we're showing you here, on the top part of the figure, what you're going to be looking at is the three different groups. So on the left is Down syndrome, the middle autosomal dominant, and then the controls. This estimated degrees of freedom, or EDFs, if it's 1, it says that there's a linear relationship with volume over their volume changes with regards to EYO. If it's greater than 1, that means there's those darker colors that are present in those individuals, that it's a nonlinear relationship. And you can see on that left-hand side in the Down syndrome, there are some nonlinear relationships, but mostly the brain is white, meaning that there is mostly a linear relationship that's seen. Those areas that are not nonlinear are some of the frontal areas and the temporal areas. In contrast, you can see quickly in autosomal dominant, there is a highly significant nonlinear relationship, aka an inflection point that is going on throughout the cortex as well as in subcortical areas. And then we look at the controls, there are minimal regions that are having this nonlinear relationship, meaning that in most individuals there's a gradual decline. On the bottom images is what we're doing is now subtracting or comparing these two different groups. So it's either Down syndrome versus controls, the autosomal dominant versus the controls, or Down syndrome versus autosomal dominant. And what you can see on the bottom part of that figure is, again, in blues, again, are saying that there are significant differences, meaning there is a greater change in the Down syndrome versus control. And the comparison, the autosomal dominant versus control, again showing these high areas of inflection points that are present, and then the Down syndrome versus autosomal dominant, you can see that there are differences, and specifically in posterior regions of the brain. And so what, as you can see, is that in general, in Down syndrome and controls, they had a relatively linear relationship. And also what we're starting to see is that even though there is this linear relationship, it's a more steeper relationship for Down syndrome compared to the controls. In contrast, in autosomal dominant, it's a primarily nonlinear, aka an inflection point that's occurring in these individuals. And you can now see that in some of these regions that we've chosen. So we've either looked at, and James also, Dr. Peterson looked at this as well. Dr. Kennedy looked at this before, is that we have either the actual or the adjusted individuals, and you can see in green are controls, in our autosomal dominant are the blue, and then in the red are Down syndrome. You can see this nice inflection point that is present in most of these individuals with autosomal dominant versus, again, a more steeper decline in Down syndrome compared to the controls. When we looked at when this inflection point was occurring in autosomal dominant, it varied with different regions, but on average it was at -5 EYO, suggesting that really there's very similarities in regards to volume until about EYO of 5, and then we see this significant decline. What I'd also have you look at is in these images as well, across each of these different regions, by the time we get to EYO greater than 0, especially by EYO 10, there is less individuals in that, but you can see that autosomal dominant has caught up or even sometimes exceeded those changes that we see with Down syndrome. We can also look at this by different kind of epochs of looking at this. So EYO of -20, -10, 0, or 10. And you can see versus Down syndrome versus autosomal dominant on the left, autosomal dominant versus control in the middle, and then Down syndrome versus controls. So on the left, when we look at the Down syndrome versus autosomal dominant, you can see that there are some regions that are in blue, meaning that these are regions that are greater in Down syndrome versus autosomal dominant with each of those EYOs. As we start to get to EYO 0, you see less and less of those blues, and then by the time we get to EYO of 10, it's now more red, suggesting that our autosomal dominant has caught up and now has exceeded, and there's actually more changes within autosomal dominant than in Down syndrome. When we compare each of the groups compared to controls in the autosomal dominant, you see that there are really no changes throughout the brain until you get to EYO 10, and now you see these large blue changes, aka large amounts of atrophy that's occurring in these individuals. And then when we compare Down syndrome and controls, again, in these different regions, you can see that there's primarily a posterior and also somewhat temporal predominance in these individuals, and that there is a greater decline, aka more blue changes that are seen in Down syndrome because it's a steeper decline compared to controls. Then we also looked at it with regards to amyloid PET. So this was in centiloids as well as volume differences, volume shapes, and then we compared them for either Down syndrome, autosomal dominant, or Down syndrome versus autosomal dominant. What you can see is, again, looking at these kinds of colors, if you see it's more white or slightly pink, that means there's not a lot of changes or there is more of a linear relationship with this. If you see really big splashes of color, then that says that there is a nonlinear relationship. And what I'd show you is that in Down syndrome and autosomal dominant, they look very, very similar. On average, it is more of a linear relationship that is between these areas. There may be subtle differences, and then some of those areas that we've looked at, and specifically in the visual cortex, and we were hearing about some of those kinds of changes, there are subtle differences between Down syndrome and autosomal dominant. So in general, there's volume versus amyloid changes are linear, meaning that higher amounts of amyloid are associated with lower volumes within most of the cortical regions. There are some subcortical regions that may be a little bit different in these kinds of relationships. And then you can see, again, these are the same kinds of relationships plotted for those three regions that we chose before, the accumbens, the hippocampus, and the precuneus. And in general, again, a higher amount of amyloid is associated with lower brain volumes, and that in Down syndrome, they're starting off at that lower point, but then if we adjust it, then there are no differences between the two groups. With regards to cortical thickness, James has also looked at this, Dr. Kennedy has looked at this with regards to Down syndrome progression. So he examined if cortical thinning patterns and subcortical volumes could identify stages of the pathology, and looked at 3 different groups, either those that are cognitively stable, those with preclinical or symptomatic impairment with Down syndrome. And then we looked at thinning, and what you can start to see is those areas that are in red are where it is compared to the controls. There's significant thinning. Again, this posterior predominance that's seen in individuals specifically with impairment, and then even in those individuals that have cognitively stable amyloid positive versus those that are impaired amyloid positive, you can see that, again, these more parietal and posterior regions seem to be affected. And said, when he looked at this and the ability for discriminating for these kinds of changes, cortical thickening had a slightly better discriminative measure than even the subcortical areas, and that subcortical areas are a little bit inconsistent with the degrees of staging of pathology. And then when he compared this in autosomal dominant Down syndrome, or the differences, and the more recent paper that's come out with this, you can see that in general, those areas that are in blue are a large amount of thinning of those regions, and you can see the difference images in green are those regions that are primarily affected in Down syndrome. In red are those areas that are affected in autosomal dominant, and that in white is the areas in overlap. So again, both of these diseases are more posterior predominant, but what you do see is that it's a lot more of a diffuse pattern in Down syndrome compared to autosomal dominant. So in conclusion, Down syndrome and the siblings controls exhibit primarily a linear decline with increasing EYO, but it is a steeper decline in Down syndrome compared to the sibling controls. This rated decline does not typically increase with amyloid conversion, and that autosomal dominant volumes are similar to sibling controls until they hit that inflection point, and then as they appear closer to those EYO or symptom onset, there's this sudden precipitous decline. The earliest divergences we could see is at -6 EYO, and that was in the nucleus accumbens. Most have this inflection point, and then there's significant volume decline such that by the end, autosomal dominant has greater atrophy changes than in Down syndrome. With regards to the effects or the relationships between amyloid, we see similar relationships between Down syndrome and autosomal dominant. And then the similar, despite this relatively similar patterns for amyloid and tau, we do see a lot of differences with regards to N and the ATN staging of individuals, where autosomal dominant Down syndrome have very different relationships. What's also interesting to us is that even though we're looking at 2 different Ns, either A with FDG PET, where we've looked at this and I'm showing you earlier results, or with the brain volumetrics, in both of these cases, it looks like there's a gradual decline in Down syndrome compared to autosomal dominant, where we, in both of those techniques, see this strong inflection point. And that this Down syndrome thinning, the DS thinning pattern suggests that DSAD is, again, more widespread and better predictability than autosomal dominant. So then the question is, why is this important? And we've been discussing, and in the next session, we'll be talking about anti-amyloid treatments and how they may affect, and there are some groups that have been looking at this throughout the world, of looking at their effects on brain volume. So amyloid and volume are highly linked in both of these groups. The question is, if we give anti-amyloid therapies to these individuals, does that become uncoupled? And that there has been some results that have shown that anti-antibody interventions may lead to a reduction in the brain volume. And the question is this from neuronal loss? Is this from taking out the amyloid? Is this from edema or something else that's now being reduced? We need to understand, and we need to understand what that trajectory of those individuals would typically be, and then if they're now getting anti-amyloid therapies, how will that change the brain volume? So will interventions temporarily increase volume loss? We don't know, but this gives us that kind of roadmap to look at that, or when will interventions need to be given to prevent some of these neurodegenerative changes? And so I do see this as an important feature for us when we're future evaluating these different therapies we're giving to our population. So this is really a reflection of Dr. Kennedy and the rest of the group that I'm so fortunate enough to work with, as well as all of my ABCDS collaborators and Diane cohort. And I want to thank our funding sources. And most importantly, I want to thank all of our amazing participants and their families. We wouldn't be here without them, and we're so blessed to work with such a great group. So thank you so much.
Okay, shall we open the floor up? For questions? Is there a microphone we can pass around? Anyone want to take the first questions? Yeah.
I could use my big boy voice if I can. I have a question for you. I know that there's been some research showing that there's beta amyloid deposits in the lens of behind people with Down syndrome. I'm just wondering how promising you think that is, and does that correlate with the beta amyloid deposit in the retina at all?
So the study I mentioned, the REVEAL study, which we is now underway, we actually assessing, looking at signs of amyloid in the lens. But I don't think any studies have been looked at, the relation between retinal amyloid and lens amyloid. I can't answer the question whether there's any correlation with that. But we do know that, so our group previously did show the presence of amyloid in people with Down syndrome in the lens. But there's no, it is difficult to assess,
Mike, you had.
Great presentations. I have a question for Agnes about the asymmetry that you saw and its relationship to the E3 homozygotes. That's a little surprising to me, and I don't think you commented on what your hypotheses are for that observation. We would expect E4 homozygotes to have the greatest asymmetry, or at least the greatest atrophy. So do you have any comments about this finding?
I have to say, sorry, that for us it was also a little bit surprising at the beginning, and after thinking about, I think that the only clear statement to say something I can say is that we think that the cortical brain asymmetry can be associated with some biological risk factors, but we don't have a clear explanation of why it's APOE3/3 and not, for example, APOE4/4. But we think that maybe it could be associated that we know that the ADAD frequency of atypical AD is low, but maybe it could be an explanation. But clearly our next steps is to try to understand more why this is happening and try to understand and explaining if there's something else. So we are starting a line to study this APOE relation with brain asymmetry more in detail in ADAD and also in sporadic AD. So I'm so sorry, but I don't have a clear answer. We have a lot of hypotheses, but not a clear answer to explain these surprising results that I totally agree that it were surprisingly.
Thank you. One other question for Bo, which is the decoupling with neurodegeneration in Down syndrome. Do you think that the developmental changes that we see in the morphology of the Down syndrome brain really are explaining that difference that you're seeing in the N category of ATN?
That's a good question, Mike. I don't think there's as much of a decoupling in Down syndrome as there is actually in autosomal dominant Alzheimer's disease. So when we did the adjusted, they actually look pretty similar to, it's a little steeper than what we would typically see with typical aging, but it does not look that much different. In contrast, it's the autosomal dominant that have that more of an inflection point in that kind of change. So that uncoupling that's occurring, I don't know why that's occurring more in autosomal dominant. Why is it all of a sudden occurring with that? We tried to, but we don't have a large enough sample for different groups to even look at mutation type with autosomal dominant, but I don't have a good answer as to why that significant change all of a sudden occurs.
And any clinical changes with those inflection points?
I mean, it's at EYO -5, so you're going to start to see some of the cognitive changes that are occurring at that, and we definitely see the cognitive changes in autosomal dominant around that age, if not maybe around that age or to EYO 0. It just depends upon how good you are and astute you are and kind of noticing those kinds of changes.
I'd be curious about MCRT at the inflection point.
Yeah. Alex.
Great presentation, very nice session. I wanted to jump in about this question of the inflection point and the volume. In the DABNI cohort, we also explored the evolution of volume with AO, and we were actually seeing nonlinear evolution, which make me think whether we are modeling the things differently or maybe some aspect of our cohort are different. For instance, we may have more in DABNI of patients at the symptomatic stage, which can allow us to modelize more the advanced stage of the disease and this drop. Do you have some insight about this? And in the continuity of this comment, just another one. I noticed that the evolution of volume in the EO10 was increased volume in parietal structure in Down syndrome?
It's not, so it's blue, it's actually decreasing, so it was decreased.
But they were red, right?
We'll have to look back at that. We can talk about that.
Okay.
I may not remember everything that's in the things, but that's a good question. So you're right. So in ABCDS, we have less symptomatic. We do have some. I mean, there's a fair amount. And if you looked at some of the early slides of the demographics, there are some symptomatic. We don't have as many as here in Barcelona. It would be very interesting to also, and we've been having these same kinds of discussions of bringing all of this together. I do think that we have good numbers with the 300 to 400, so I feel reasonably confident on that, but I think the more the merrier, because then we can really understand this more. So I agree, more exploration and more bringing groups together is going to be very important.
Totally.
Marie-Claude.
Yes, thanks a lot. Just to continue the question of Mike to Agnes on the asymmetry. So I think there are data in very young APOE4 carrier, like adolescents, showing differences in the volumes. I don't remember if it's really asymmetry, but and suggesting that there could be some developmental defects in the development of the brain. So do you think that what you see could be related to this early development of the brain as it has been reported, for example, in Huntington disease?
I think that not. I think that are different things, but as I explained before, I think that the APOE3/3 brain asymmetry, I think that it has to be studied more. I do not mention, but we have some preliminary analysis in the way that we have a very small sample in the clinic Barcelona cohort that I don't show because there's not so diversity in the APOE genotypes, but it's similar results as the DIAN-OBS cohort. And also we studied the presenilin 1 and APP because presenilin 2, we don't have enough data in DIAN-OBS, so we divide the 3 mutations except the presenilin 2, and we again have the same results when we divide. So it seems that the APOE4 has the lowest, well, not the lowest, but it's lower than the APOE3/3 or APOE3/4 that also present a higher brain asymmetry. But as I mentioned, we don't have a clear reason of why, so we need to study more with more cohorts and in more detail.
Are there other questions? If not, I'll take a question. Alejandra, I thought you did a great job there. It was very interesting with the PSMD. It had a lot of correlations with a lot of different things, so NFL to white matter hyperintensities to bleeds. What is it reflecting, and did you also look at GFAP and the role of inflammation? Is there some, because when I think of mean diffusivity, I'm also thinking of an inflammatory component?
Yeah, thanks for the question. We didn't include in this analysis, but we wanted to include the GFAP and also the ILK40 because we see a significant difference in our white matter hair brain density with the DABNI cohort, and there is not only the neurofilament, also these inflammatory markers, so we expected that with PSND, there is the contribution of the inflammatory in this metric reflected.
Any more questions from the floor? I've got a question for Leos. I always find your talks fascinating and feel that this is such an unstudied area, and you learn a lot from the references. But I wanted to ask, the choroidal thickness that you've seen in Down syndrome, have you been able to study a wide enough range of people to see if that, at an individual level, does that change? Is that dynamic through the course of the disease? Because just sort of also thinking about some of the other talks, there is this really interesting literature on dynamic changes in brain volume, and I remember speaking to Juan about this like 15 years ago when we first met, and I think we do need to always keep in mind that we lose that possibility to see dynamic changes when we look at group level, just at group level data. So have you been able to look at that? Does it change?
Yeah, so that's again what we do now, the REVEAL study, which is underway. We will look at these, but there are no. So I think what we know at this point, that this thickening is a feature of an older population, and that's not visible in childhood. But we don't have the so there are gaps in age range, so we don't really know how it changes over the lifespan. So there would be needed longitudinal studies for that, and studies that look at wider age range, which we don't have.
Maybe just to follow on about the sort of detection of amyloid beta in the blood vessels, is there any literature from the sporadic CAA field about what we might detect in the eye? Again, I think our fields can, that whole area, we often don't draw so much on what we could learn from that and in respect to the eye. Yeah,
and that's again missing from the literature, so I'm not aware of any studies looking at that. But there is a study, a deep and frequent phenotyping study on prodromal cases from the sporadic population, or the general population in the UK with several sites. We have about 100 people following up for a year, and in that we use ultraviolet field imaging, the imaging modality I showed you. We used in Down syndrome as well, and that allows you to assess blood vessel damage there. So be able to assess that, and so hopefully very soon we are completing now the study. So hopefully very soon we can report on that as well.
Fantastic.
So I'm going to just ask you too, Laos. You have the audience here right now, and you have potential neuropathologists here. So what would you want to look at in the eyes of individuals? And what would you look at for the pathology, and how would you ask them if you have a captive audience here?
Yeah, on postmortem samples, right? So we would definitely need to look at the presence of amyloid beta in the blood vessels, in the retinal blood vessels, as well as in the choroidal blood vessels. And it would be also important to look at different areas of the retina, because what we find, where we find the damage of the blood vessel, that was exclusively in the peripheral retina, which is not often looked at. So most of the ophthalmology practice or clinical practice would look at central retinal changes, because that's where your central vision is. So this is the most important. That would affect your life, and the peripheral retina is sort of disregarded. So this might be the reason we miss these sort of changes, and we don't know much about these changes. So I think it would be important to locate which area is affected. I guess.
I think that's a really good sort of discussion to open up to the room, actually. I mean, our experience in autosomal dominant Alzheimer's disease about discussing brain donation has been that, many family members are really keen to register for this, and it's something we discuss very early. It's very much part of the, when you join the DIAN study, for example, it's one of the things we talk about. And I wonder, is that happening in the Down syndrome field? And for the eye as well, again, it's something we've not been thinking about, but actually, should we be working together to try and fill that gap in our knowledge? Because we've now got all these amazing biomarkers in life, and we need to understand what they mean for pathology. Does anyone want to comment on that? Mike?
So ABCDS and TrackDS both have a brain donation program. It is an important conversation to have. We do it with ACTC for our clinical trials in general. I don't think the uptake has been that high, but I've had cases where we've obtained brain, eyes, and spinal cord. And just as an aside, we've stained the eyes. We see tangles in the retina, neurofibrillary tangles. So it's very important, I think, with any of these biomarkers to image the individual and do the clinical pathological correlation with that individual. And I think brain donation should be pursued in all of these observational studies for that fact that if it does happen, you'd be able to do that correlation in that individual.
Can I ask about CAA in the eye? Did you look at that?
We did not see a lot of CAA, and with the DSAD paper, we saw curcumin binding to what looked like perivascular punctate plaques, but we don't know what species of amyloid those were. These individuals did not come to autopsy to do that final study. And Brian mentioned the lens study. That's another tricky one where they described what looks like fibrillar amyloid, but we don't know what species. Is it 42? Is it 40? Is it something else? Is it amyloid-like? And so I think that's where we really need to correlate whatever the biomarker is with that individual's pathology. And I think brain donation is the key. I don't know if Dabney has brain donation one.
We have, as you say, I mean, I think we're in collaboration with the Barcelona Brain Bank of Hospital Clinic. I think that we've got like 18 brains from Down syndrome, six are before Dabney, and 12 are from the Dabney cohort. Some of them that were presented there, they do have CSF and so on, but we are not collecting eyes. This is something that we could eventually, I know that sometimes they do. We are discussing because Raquel is very much involved in the brain bank, but this is something certainly that could be really interesting to add. And on top of the amazing job that the ABCDS, Liz Head is doing in Brain Bank, I also want to do a kudos for Lotta Granholm, that I think that has been also championing a global brain bank and helping many countries outside the US, so including us and in the UK and in other countries, in having like a platform. So I think that for those that are interested in brains with brain bank, with DS, I think that we have here in Barcelona, then is the ABCDS, and I'd say that also Lotta, they have that decentralized brain bank, but it keeps track of the brains available worldwide, and there are resources out there to reach. And to the question of the eye, we've mentioned that in private conversations, but Liz Head, I know that from her legacy cohort in Kentucky, she has quite a few eyes from people with Down syndrome.
Marie-Claude.
Yeah, just to mention that there is a working group, neuropathology working group of the Trisomy 21 Research Society, led by Lotta Granholm, and you can access also their website And it's an initiative in the US and in Europe with several sites, including the Brain Bank in Barcelona, in Paris, and I don't remember exactly, in UK, of course. So you can have access to all the samples which are available through them.
Sounds like you're going to be busy. No, but I think it's really important because the resources are often out there, but you don't necessarily know about them. And so hopefully this is one of the great things this conference can help with is just those connections.
So just as a comment, we did a lot of work with the UCL Biobank and the King's Biobank trying to convince them to start collecting eyes. There is an aversion to do that. Brain banks believe that if they ask for eye donation, then people might say, oh, then I don't donate the brain either. It probably is worthwhile revisiting that. That was a few years ago, especially now that more eye studies are creeping into the neurology domain. So patients are very happy. That's our experience through the deep and frequent phenotyping and other studies in Northern Ireland, that they are very, very willing to come, and they enjoy the rapid collection, the visibility of the data. So maybe there is a good opportunity now emerging to ask donation of eyes together with the brain samples. So hopefully everyone will encourage their colleagues to do that.
That's really interesting. So you feel it was reluctance at the level of the brain banks because of the perception. So that's something we can explore with the families that we work with, and we run a support group for ADAD in the UK, and actually I speak much more about brain donation now because they always encourage me, say you've got to talk about it with this group. And I have a patient who used to stand there with his brain donation card in his pocket, and he'd say, if you don't bring this up, Natalie, I'm going to get it out and I'm going to stand up and talk about it myself. And so I think we need to explore where these. Of course, it's not for everybody. It's a really sensitive and important discussion that's done right, but it's important that we're having it, I think, and it's good to hear where the barriers might be. Does anyone else want to share anything on that?
Yes, my name is Laura Molina. I'm from the Barcelona Brain Bank, and I would like to add that we were exploring to get the eye of patients, but the thing is that the reason why people doesn't want to do it is because they think that the aesthetic at the end of the body is going to be compromised, but it is not, because you can put something there that is a thing that people do usually do, and it's nice. I mean, it doesn't look bad. So it's something for not to understand the family point of view of the thing. And the other thing is that you need to change their consent. Sometimes, because several times you put like is neurological tissue. For me, the eye is neurological tissue, but not everybody can share that point of view. So for us, for example, we are changing this. So we are able to get the eyes.
Thank you. Any other questions or comments on any of the brilliant talks we've heard this morning, or more generally, because this is such a unique chance for us to have these discussions?
If not, we'll first congratulate all the speakers here today. Thank you so much for a great presentation, and we'll go to a coffee break right now. Is that what? What?
Yes.
I think Juan wants to say something.
Deep within the biology of the brain is a set of intricate instructions that define who we are.
We'll have the videos, but can I have the mic? Can
The mic for 1 sec. Yeah, we have the videos but we want to do a family photo. So today the coffee is going to be outside in the garden, but before you jump into to the coffee, we'd like to have like last year a family photo. So we'll have it like last year outside, just in the garden. So we all go outside after the videos, if you don't mind. We take the photo and then we go for the coffee. But the videos are going to be there.
Well done.
Deep within the biology of the brain is a set of intricate instructions that define who we are, how we move, how we think, our very sense of self. Sometimes these instructions fail, but at Biogen, we are not afraid to go where others won't. At Biogen, we are pioneering new science that takes us deep into the body's nervous system and stretches wide across digital networks and patient communities to better understand and preserve the underlying qualities of our essential human nature. Science that transforms patient lives by improving mobility, breathing, vision, and brain health. Science that seeks to solve societal problems and create access to innovation. Biogen, where science meets humanity.
Alzheimer disconnects memories, lives, and families. Every day, millions of people around the world are affected by this disease. But at the heart of this city, a leader in cutting-edge research, a new connection is born: the Hub Alzheimer Barcelona. A unique and innovative research network that brings together public and private institutions, professionals, researchers, and civil society to move forward together in the fight against Alzheimer's. The future of Alzheimer's research begins here. Our Hub Alzheimer Barcelona. Together, we can change the future of Alzheimer's.
Good? Good? 1, 2, 3, 1, 2, 3, 1, 2, 3. I think I can hear it now, actually. How's it going? Yep. How about now? Good? Yeah.
Okay.
Yep,
perfect.
it's all good.
Thank you.
Is it on at all times?
It's off, it's off. It's off.
Cambiamos las pilas.
Bueno, en principio solo juegan dos en principio ahora, ¿eh? Bueno, si queréis cambiarlas todas, pero ya te digo.
Yo me acuerdo que
Test. 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 All set?
Okay, perfect.
Okay.
All right, Dave.
All right, you want to get started?
Yeah. Who's going first, do you know?
I see your name first, so I don't know what that means.
Okay. All right, good morning, everyone. It's a pleasure to be here. I think this second edition of this conference is a huge success, and it's a credit to all the biomarker work that's been done in the past few years. And I'm going to be giving you an overview of how those biomarkers have now led us to be able to think about clinical trials specifically designed for people with Down syndrome. And I'm going to spend the second part of my talk really getting into the practicalities of clinical trials for this population. And it's going to focus on a deep dive of recommendations from the ADAD study. So we're going to get into some detail about that trial and how it can help others who are looking at getting into this field. I'm Mike Raffi. I'm a professor of neurology at USC and work at the ACTC Clinical Trials Consortium and the Alzheimer's Therapeutic Research Institute. These are my disclosures. So again, this is something that we've already discussed, but I just want to go through it again to remind you that we're dealing with a fully penetrant form of Alzheimer's disease. We now have DSAD as stage 0 of Alzheimer's disease, which from a regulatory standpoint is very important in drug development. There's a universal presence excuse me, of AD pathology in individuals with Down syndrome by the age of 40. But as you know, this is on autopsy, and when you're running clinical trials, we're doing non-invasive imaging, and in fact, 40 may be a bit too young to say that there's amyloid positivity. There is a faster rate of progression in the disease in people with Down syndrome as compared to autosomal dominant AD and late onset AD. We now know that Alzheimer's disease is the leading cause of death in people with Down syndrome over the age of 35. And what Dr. Hardy mentioned yesterday, as there's an ethical imperative to include these individuals, couldn't be more clear than the fact that mortality is being capped by the presence of Alzheimer's disease. Average age of dementia diagnosis is 55. It's a fairly homogeneous population, and as you saw from some of the presentations earlier this morning, that we land from different cohorts right between 52 to 55 years of age with a 95% lifetime risk. And conducting clinical trials in people with Down syndrome will help inform us about how early can we go in Alzheimer's disease, both in autosomal dominant and sporadic forms of Alzheimer's disease. Remember that in Down syndrome, APP is in its native state. There are no mutations, and it most closely resembles sporadic AD. And finally, because of this rapid progression in Alzheimer's disease in this population, we expect a faster readout on our various outcome measures, both biomarker but also clinical outcome measures. So in 2018, we were funded by the NIH through the INCLUDE initiative. The INCLUDE initiative is a trans-NIH initiative where all institutes at the NIH were encouraged to include people with Down syndrome in their ongoing longitudinal studies. And at the National Institutes of Aging, the ACTC, Alzheimer's Clinical Trial Consortium, was asked in a way to leverage that infrastructure to run clinical trials for people with Down syndrome. We've established 20 sites that have unparalleled experience in DSAD. These are international sites, and we've just recently added 2 more sites in the United States, in Chicago and Cincinnati. Our first project that was funded is the Trial Ready cohort. This is based on experience that we had in previously conducting 2 clinical trials, multi-center trials in DS, and an understanding that people with Down syndrome may not always have the same access to healthcare. And when you bring them in to screen for a clinical trial, you may find undiagnosed conditions or unstable medical conditions that would preclude enrollment into the trial. So the Trial Ready cohort was really meant to understand a population phenotypically who are medically stable, interested in clinical trials, and to also serve as run-in data for clinical trials. We were initially funded to enroll 120 participants. Currently, we're at 350 participants and have been approved to enroll up to 450 individuals. Between the ages of 25 and 55, we have direct recruitment into the Trial Ready cohort. We have individuals from the Down Syndrome Connect registry, an online registry in the United States, and we allow for co-enrollment with the ADAD-DS consortium. This is the longitudinal observational study. The TRACK-DS is a lighter touch protocol, but it's based on the ADAD-DS protocol. The idea in our original proposal was to have clinical trials that individuals would be offered to participate in, where there would be rapid enrollment, and at the conclusion of those trials, these individuals would return back to that trial-ready cohort. This is very much based on another trial that the ATRI is running called TRACK-PAD, which had 60,000 people in an online registry who were then funneled into various clinical trials through ATRI. Perhaps one of the most important aspects of the work that we're doing at ACTC-DS is the establishment of a Down Syndrome Research Participant Board. This is a collaboration between ACTC-DS and ABCDS and individuals from the Down syndrome community. And it's led by Sarah Walter at USC, who also runs our partnership group with our ACTC Clinical Trials Network, and includes other individuals, Dr. Lauren Tomey, Dr. Annie Cohen, Dr. Liz Head, and myself, as well as individuals with Down syndrome and their family members. And we meet quarterly to review our protocols, our consents, our messaging, any study-related documents, and get feedback with their voice in our studies. Now, we've heard about certainly the APP metabolic pathway and its importance in driving Alzheimer's disease in people with Down syndrome. Some of the clear therapeutic targets in DSAD include the APP messenger RNA, as well as the oligomers and plaques related to A-beta. I'm very happy to say that we now have 2 ongoing clinical trials and 1 launching later this year that target these different pathways. The first study that I'm going to talk about is the HERO trial. The HERO trial is a multi-center single ascending dose study in adults with Down syndrome between the ages of 35 and 55. These individuals must be clinically asymptomatic with regards to Alzheimer's disease symptoms, so what we would refer to as cognitively stable in the ABCDS cohort. They must be amyloid PET positive, and this is something that's been evolving over the last few years, not only in the DSAD population, but also in sporadic AD, as to what is really elevated brain amyloid and how good are we at detecting that with PET. Finally, these individuals can have mild to moderate intellectual disability, and we really want them to be able to participate fully in these clinical trials procedures. The primary objective of this study is safety and tolerability. It involves an intrathecal injection of an antisense oligonucleotide targeting APP. And one of the key target engagement outcomes is the levels of soluble APP in CSF. It's a single administration with close to a year follow-up in these individuals. At the conclusion of these 3 cohorts, there will be a review of the data analysis in terms of which way to proceed and which dose to use. And I'm happy to say that our first participant enrolled last December. The next study to briefly talk about is the ALADDIN trial. This is a phase 4 trial of the already approved, FDA-approved drug donanemab. And in the Down syndrome community, there was a huge uproar that not a single person with Down syndrome was included in the thousands of participants in both the donanemab Trailblazer ALZ 2 study and the Clarity AD lecanemab trials. So this study is meant to confirm the safety, tolerability, and efficacy of donanemab in people with Down syndrome between the ages of 35 and 50 years old. They may be cognitively stable or have mild cognitive impairment, but must have evidence of elevated brain amyloid. And this is just an overview of the study design. There's a screening period. The individuals are randomized into drug or placebo. At the conclusion of a year, there will be a second PET scan done to evaluate for the amyloid level in the brain. We know that donanemab is exquisitely potent in removing amyloid from the brain. We expect the same to be the case in this population. And at the end of the year, should we see that there remains any amyloid elevation in the brain, those individuals will continue on in donanemab, while those who have had clearance will go on a placebo arm. This is a long-term extension period. Before each infusion, each of the first 5 infusions, individuals in this study will have an MRI performed. So we are being extra cautious in that regard, and we are also using the modified titration was presented from the Trailblazer ALZ 6 at CTAD last year, showing a reduction in the incidence of ARIA-H and ARIA-E. Now I'm going to talk about the ABATE trial. This is an ongoing trial. It's a phase 1b/2 trial looking at the active immunotherapy ACI 24060. Years ago, we conducted a trial of ACI 24 in individuals with Down syndrome. And in this trial, we're having two groups, individuals with prodromal AD in the general population and individuals in the Down syndrome population. And on the left, you can see it's an adaptive study design with interim analyses looking at the response to dose. And of course, response is measured not only by safety and tolerability, but also by antibody titers to this vaccine. The vaccine includes the first 15 amino acids of the A-beta peptide. Based on the dosing, and here on the right you can see, based on the dosing that we see in the AD cohort, we then moved into the selected dose or the optimal dose in the Down syndrome cohort, and that is an expansion dose, if you will. The key inclusion criteria, again, they must have elevated brain amyloid on PET. In the sporadic population, it can be individuals between the ages of 50 and 85 who have basically prodromal AD, so MCI, but with an evidence of elevated brain amyloid and a CDR of 0.5. In the Down syndrome phase, individuals between 35 and 50 who may have mild cognitive impairment or are cognitively stable. There are certain exclusionary criteria that are shared in both. So just an update, and these slides were put together with the help of course, the AC Immune team. We've completed the cohort in AD1, AD2, AD3, and these are in 3-to-1 ratio, 2-to-1 ratio, and 2-to-1 ratio in the third cohort, comparing various doses of the vaccine against placebo. And cohort AD4 is supposed to start later this year. Again, we hope that the total number of participants across these first three cohorts, 74 subjects, would inform which way we go with the AD4 dosing. The Down syndrome cohort has been based on the optimized dose from those first three Alzheimer's disease prodromal AD cohorts. We've completed the enrollment in DS1 and DS2, and DS3 is nearing completion of its enrollment. There will be a total of only 24 participants in this study. And the primary aim, of course, is safety, tolerability, and again, antibody titers. In the previous trial that we conducted, the phase 1b study, we only had about 25% of individuals with Down syndrome develop antibody titers against this vaccine. So this study is looking at a reformulated vaccine to develop a greater antibody response. Now, I want to talk about some of the learnings from the ABATE trial as we think about additional trials coming online for this population. Main challenge has been bringing people in to screen, and there's a reluctance by some people in the community to participate in clinical trials. They don't want to be guinea pigs. They have active lives. Obviously, they don't want to sacrifice that time being in a clinical setting, and we completely understand that. Others have comorbidities that exclude them from participating in studies. Once they do screen for the study, we are seeing about a 55% screen fail rate. And the main reason for this is PET ineligibility. So as I mentioned earlier, the participants in this population can be between the ages of 35 and 50. And we're seeing that on PET scans, those individuals between 35 and 45, the large majority of them are PET negative. And so there's a high screen fail rate in that regard. Another finding is that some of the individuals have claustrophobia or are unable to participate in MRIs, which in some of the amyloid targeting trials are critical in ensuring safety. So recommendation number one is to get to know the population, get to know their needs, understand their daily routines, if they have day programs or jobs that they're involved in, their commitments that may impact their ability to come into study procedures. Consider the constraints of older parents or siblings that may have their own lives with very busy schedules, and try to engage with advocacy groups to hear feedback, what's the best way to schedule the visits, what time of day, what day of week. Balance their needs, but of course not compromise the integrity of the study. So we've tried with the ABATE study to reduce the number of on-site visits as much as possible and use phone visits. We've tried to use home visits in some cases if it reduces burden on the participants. And we try to combine as many assessments as possible in a single day, knowing that it can be a long day, but that may be what some participants prefer. And as I mentioned in the last bullet there, if possible, to get the population to comment on your protocol. We actually went through a NDA agreement, confidentiality agreement with our individuals on the Down Syndrome Participant Research Partnership Group, and they understood that they need to keep this in effect secret, and they understood, people with Down syndrome understood that this is not something that we should be talking about publicly, and they have not. We want to educate the population, and our education needs to be homogeneous, it needs to be consistent. Questions about the prevalence of Alzheimer's disease in this population, or even the link between Alzheimer's disease and this population, is still unknown by a large majority of people. And so just educating the population, I think, is an important first step. Trying to help them understand the study procedures and to understand what is involved in terms of the commitment, because the last thing you want is to vaccinate someone with an anti-amyloid vaccine and then lose them to follow-up. So we want to ensure that they're going to come back and complete the study. In ABATE, we also have a concierge service that allows facilitation for travel and reimbursement to the sites. Recommendation number 2 is communication strategy from the beginning. So the ABATE study has utilized flyers, social media, webinars, in-person events, and I would say the in-person events that are on site, that let the family members see the site, tour the MRI facility, look at the infusion center. They get that firsthand knowledge of what it looks like, what's the parking like. That is a huge obstacle that you can overcome with this population, as with any population. And of course, consistent messaging is key. Recommendation number 3 is to adapt the communication style. In our AD trials, we talk about what grade level the reading material should be in, and we've discussed with advocacy group what the reading level should be in our families with Down syndrome. We want to use the easy read method that's used in the UK and adapted in the United States. We want to avoid technical jargon, particularly in the consent form, but to be clear about what this study really involves. And we've used videos, and the ABATE study does have videos online showing what an MRI procedure is like, what a PET scan procedure is like, and I think that's been very helpful. And we want to allow participants and their families to have time to think about this. So our screening windows are actually expanded in our DSAD trials. We can go as much as 90 days for some of our screening periods. And I think that allows them time to acclimate to the procedures that need to be done. But we also need to have an expanded period where they think about even screening in the first place and providing consent. Recommendation number 4 is thinking about the eligibility criteria. And some coexisting conditions in Down syndrome can impact cognition, can impact the rate of decline. Sleep apnea is one. Hypothyroidism is another one. Very high prevalence that needs to be under control before they can screen for the study. Perhaps the most important learning is the amyloid PET criteria. My recommendation is that you both use quantitative reads and visual reads when you're allowing eligibility for these trials. And we see particularly in the DS PET scans that depending on the tracer that you use, the signal may be more in the basal ganglia as opposed to the cortical ribbon. And so that impacts eligibility to a huge extent. And we just want to make sure you understand those nuances when designing your trial. We now have an FDA-approved blood test for Alzheimer's disease. Our group has been validating various blood tests, plasma assays for p-tau217 and A-beta ratios, and we're incorporating those in the HERO trial and also in the ALADDIN trial. But it's very important to be able to enrich the population, even in this genetic population, given that the number of people that we see who are amyloid PET negative in the group that we're targeting. Other things to think about include this balance where we want to go early. We know it's a genetic condition, but we need them to confirm target engagement. And so you need to have amyloid PET positivity. But if you go older, you might have symptom onset that precludes their ability to participate, or you may have risk of some adverse events with a greater amyloid load. So there's a balance that needs to be achieved. And given the fact that they go from amyloid PET positivity to tau positivity in 2 years, you have a narrow window. Recommendation number 5 is to, again, manage the individual's expectations and their risks and their anxiety and their discomfort going through this trial. We do this with all of our AD trials. We must do the same in this population. But there are some unique characteristics here that we've implemented. So ECG lead stickers that are skin sensitive, topical anesthetics before blood draws, imaging procedures like MRI that allow the use of MRI-compatible headphones where they could listen to music. This reduces burden and allows for greater compliance. And we try to reduce the number of invasive procedures, including the blood draws and the LPs. And remember, things such as the CSSRS and other scales do have pediatric versions that can be adapted to this population and accepted by the regulatory agencies. Recommendation number 6 is that right now, it's a very exciting time in the field, but there are very few competing trials. And it may not always be the same in the future. It's a very opportune time, but you have to keep in mind that the sites that are engaging in these trials are aware of what the commitment is, what the burden is, that the sites are ready. And the Trial Ready Cohort is meant to help with that, but you want to make sure that the sites are prepared to manage all the complexities of running a trial in this population. And finally, recommendation number 7, and I think this is something we all need to work on, which is educating the community, whether it's through webinars, educational materials, engaging with them in various venues, but not only to talk about the link of Alzheimer's disease and Down syndrome, but the number of research opportunities. We've heard about so many observational studies, DABNI and ABCDS, 2 of the largest, but also the opportunity to get involved in clinical trials and be proactive. The local associations and the national associations have been incredibly helpful. NDSS and Global Down Syndrome Foundation have been partners in our ability to bring these trials to the community, and without them, we really wouldn't be able to have all the activity that we have. So just some concluding remarks. We know about the genetic basis of Alzheimer's disease in this population. You've seen from so many biomarker studies that it progresses more rapidly, but is essentially materially identical. We've seen that the Down syndrome community is ready and willing and able to participate in clinical trials. They have been excluded for the past 30 years. The Glenner and Wong paper in 1984 that was mentioned yesterday, we've known about it really since then and haven't really done much about it. And in the past 10 years, there has been incredible growth in the field. We're now able to have a conference dedicated to this field. It's unbelievable. And now we can talk about clinical trials. The trials have to be tailored to this population, and I'm very happy to say that we have 3 trials specifically designed for these individuals, and we will have more trials in the future. We want to thank all the sites that are involved, and the site PIs that are involved in the ABATE study. It's an international study, and we want to thank, of course, all the participants and their families who are so dedicated in these trials. I have 2 additional resources up here for you. One is a workshop that we had with the Include initiative discussing the sort of the best practices for conducting clinical trials. And one of the co-authors is a mom. One of the co-authors of this paper is a parent of someone with Down syndrome, and we included many of the recommendations from their perspective. And there was a paper now a number of years ago on some outcome measures that may be useful and accepted by regulatory agencies for this population. And of course, the ACTC leadership and the ACTC-DS partners, ABCDS, Global National Down Syndrome Society, and the Include initiative that have allowed for all this work to happen. Thank you very much.
Thanks, Mike. All right, so thanks a lot. Can you hear me? Yep. Okay, so fantastic job, Mike. Thanks for setting that up. Raquel and Juan, thank you so much. Honestly, I could not attend last year. I was virtual, and it's just been such a fantastic conference. And the thing I've been really impressed about before opening my talk today is the amount of data now that's coming out from the Downs cohorts. It's really, really great to see all the work that's gone into this actually now coming up with this data, which Mike emphasized, and I'll actually talk a lot about how we've used this in the autosomal dominant cohort. this is really critical to how you think about the disease, how you think you should set up your trials, how you'll be surprised, and then how you'll use that data to sort of continue to refine and make these trials better. So I think this is a fantastic forum, and thanks to the Alzheimer's Association too for their support and everyone else that supported it. So with that, I am here on behalf of the DIAN study. My name is Eric McDade. I'm a professor of neurology at WashU, and I will talk today about the primary prevention trial platform. But before I get there, I'm actually going to go through sort of how we got there and how we're using the data that we've been accumulating in this program to help us make these trials better. So I'll start off here to sort of give us a sense of where we are with the state of autosomal dominant or dominantly inherited Alzheimer's interventional trials. So this is a summary actually of where we are when we think about those trials that at least are registered within clinicaltrials.gov. And what you'll see here is that there's not many, right? So when we talk about Down syndrome, it's great to see these trials coming up and sort of where they are right now. But similar to Down syndrome, what we've known for years, we've also known for many years about autosomal dominant Alzheimer's disease. And it's really within the past decade to decade and a half that these trials have evolved in parallel to these longitudinal studies that provide us this data. So you'll see here we have everything from phase 2-3 studies that have gone out to over 10 years of intervention, starting with the DIAN-TU-001 study with gantenerumab and solanezumab that then led to the open label extension, which then now has led to this thing called the amyloid removal therapy trial, which I haven't listed here. We're now moving into things like phase 1B studies for this population. And then the other large trial cohort is from Francisco Lopera's work that he's done in Colombia with the partnership that they've had with Banner and with Eric Ryman through the API studies. So it's great to where we are, but there's a lot more that we need to do with this. This is another really important thing too that we've learned, I think, from these trials. So one of the major concerns and major questions, it's starting to sort of go away when we submit grants and we submit papers about dominantly inherited Alzheimer's disease, is how well it reflects the sort of more common forms of Alzheimer's disease. And I think this will be the case with Down syndrome. And it's important for a couple of reasons, one of which is when you're engaging your pharmaceutical and biotech partners who are coming up with these therapies, this is an opportunity for efficiency in clinical trials, but we also want to show how we can actually leverage this data and the learnings from this to the broader Alzheimer's disease population. And so the other important thing is it also helps with efficiencies when we think about things like running a trial in Down syndrome with donanemab. Well, can then we run a similar trial in autosomal dominant or sporadic Alzheimer's disease with that same compound? And can we use both of those trials to maybe register a drug or maybe get a drug to both populations more quickly? And that's going to be very much dependent on the outcomes of those trials and the mechanism of action. So when we look at the soluble A-beta antibodies or the plaque binding antibodies, what you find here is the studies that were done in either prevention or in symptomatic and autosomal dominant, and you can see these listed here in blue. Those trials that are listed in green essentially show significant similarities between what we found in the autosomal dominant population and what we ended up finding in the dominantly inherited population. So this becomes really helpful too when we move forward, when we think about these trials too, when we're setting them up, and then when we're going to the regulatory agencies to say we think we could do this smaller trial, because you see things like recruitment issues that may happen with Down syndrome. You may not have the opportunity to run a trial with 500, 600, 700, 800 people, but if you can run a smaller trial and get important information that you match with a late onset or autosomal dominant, this may help to accelerate treatment opportunities for both populations. So a lot of this stuff I'm going to go through right now, this is mostly published data. Many of you are aware of it. Some of it's new data that I'll provide, but really how have we been using this? And I'll show sort of as the data accumulates how we start to think about using this more. So this is not a surprise to anyone when we think about the dominantly inherited population. There's a convergence essentially on how these mutations, most of these mutations, either point mutations or duplications, or in some rare cases, some of the deletions, they all converge through that amyloid pathway. and subsequently they lead to this convergence on the development early in life, much earlier in life, of amyloid plaques. And then we use this with the predictability in that bottom plot there of the estimated age of onset, and then you start to map out how your biomarkers are changing. Importantly though, too, and I think this will be helpful too, as the Downs cohorts continue to accumulate more individuals and more data, you'll find too this issue with heterogeneity. So again, the assumption about autosomal dominant Alzheimer's disease, the estimated years of onset ends up being really good, but depending on the mutation, there ends up being significant variability in there. And so the earlier you can start to model and figure out why you have this variability, the better you'll be able to account for this when you think about where an individual should be for a clinical trial perspective. So there's been a tremendous amount of work in this that actually shows within the autosomal dominant population, depending on the biomarker that you're using, there could be significant differences in the years from when these develop within the population. And that's really important when you're thinking about balancing your clinical trial populations as well. So as we know, the predictability of the symptom onset is great. And so with the Downs cohorts too, as much as you can anchor that to your amyloid pathology, this becomes incredibly important. So this is a study that was done recently with Patrick Luckett, was working with Bo Ansis. And essentially here you're just looking at the predictability score between these different biomarkers is separated in non-carriers and carriers. And you'll be able to do this within Downs in certain ways, and you use these different biomarkers. One of the things that I haven't seen much from this conference, and I think is going to be really important with the Downs cohort, is the inclusion of tau PET to understand how to use that and how this pathology develops in the Downs cohort as well. And the reason being is this is one of the things that we were most surprised about with when Brian Gordon published this paper. This was the initial tau PET data from autosomal dominant Alzheimer's disease. And so again, when we thought about this issue of the sort of Braak staging and this evolution of hippocampal neurofibrillary tangles that then spread to the cortex as symptoms develop, at least with the tau PET tracers that are out there, so far we continue to see this very interesting sort of pattern in autosomal dominant, which is when individuals are asymptomatic, that's the top row, there's really no differences that we can see between carriers and non-carriers. It's that symptomatic point where you get this tremendous increase in tau PET, and you get this interesting development too, that typically it starts in the autosomal dominant population in the parietal cortex, in the mesial parietal cortex, in the lateral parietal cortex too, which does not follow that sort of typical Braak staging pathology. This is one of the areas that we do find this to be quite distinct from what we often see in sporadic Alzheimer's disease. And again, this becomes important when you're thinking about potentially using this as a biomarker in a clinical trial if you're making assumptions on where that pathology should be. We've done a tremendous amount of work in parallel with the sporadic Alzheimer's disease populations on looking at the soluble tau aspect. And again, the reason this becomes important too is, as many of you know now, there's these multiple phases of how the tau pathology develops either in plasma or in CSF. And I'll show you how we've been using that to essentially use the clinical trials to try to validate what we assumed was happening between the different pathologies and at different stages of the disease. So you have the early sort of CSF 217, 181, and then you get 205, MTBR 243 comes in here along with your neurodegeneration, and then our population tau PET really launches right at that symptomatic stage. And then I think really importantly too is now that, again, these populations have the autosomal dominant population, as we have more data and as the opportunities for how we measure the disease evolves, we have these great sort of opportunities too. And so Juan Fortea mentioned Eric Johnson's work that was recently published comparing the proteomic approach of looking at CSF proteomics in autosomal dominant and Down syndrome. And this is recent work from Carlos Cruchaga's lab using proteomics, a different proteomic platform. And what it allows you to do is begin to think about the next stage of interventions, but then also when we're doing things like prevention studies, can we continue to build in robust biomarkers beyond just things like amyloid and tau and fill those gaps to demonstrate that we're having a significant impact on some of these early synaptic pathways if we're doing primary prevention studies. and how reliable are these proteomics for measuring outcomes and longitudinal data. This is a paper that's about to come out as well with a fellow that was working with us, Haiyan Liu, and this, I think, becomes important with actually thinking about how these mutations might be working. And specifically, this is work that actually looks at the ubiquitin system and the proteolysis system. And what Haiyan found was this very interesting finding is that the strongest correlations that we had between these biomarkers of the proteostasis system were with the sort of later stage tau pathology. So we had this assumption that with an autosomal dominant Alzheimer's disease, you have these mutations that alter amyloid, and then you get an internalization, you get endosomal swelling, and so we actually thought we'd start to see these correlated very strongly with the amyloid pathology, but we did in fact didn't see that. What we saw was a later stage development in association with these, along with tau pathology. So can we use this data now to think about our tau interventions, or can we use this data to think about if we intervene at a really early stage of the disease, can we normalize this and give us greater confidence that we're altering the trajectory of the disease? And then, as was mentioned, I think as Julie did a very nice study on the clocks, this is becoming really important too, these sort of amyloid clocks or these different pathological clocks. This becomes incredibly important, and I think the sooner you can do this with the Downs cohort too, the better, because what it allows you then to do is to essentially standardize the diseases between autosomal dominant, Down syndrome, sporadic Alzheimer's disease on this kind of universal timeline. And then it allows you to think about what happens in early phase disease and what happens in later phase disease with your different biomarkers, and what are your similarities and what are your differences. What's causing that mechanistically provides opportunities to look into that. Plus, you start to think about your interventions and how can you use the trial outcomes from sporadic Alzheimer's disease and autosomal dominant Alzheimer's disease to potentially make your trials better in Downs as well. So what have we learned from the clinical trials with that disease progression aspect in line? Well, here's one of the first important things that we learned, right? So this was from the DIAN-TU 001 study. So this was looking at amyloid lowering with, in blue you see here with gantenerumab, and in red you see solanezumab. And what this plot is doing is on the left of both of these, that's the asymptomatic cohort, and on the right is the symptomatic cohort. And although these trials weren't powered sufficiently to look at these two groups separately, the assumption, actually when we started the trial back in 2012, when Randy Bateman started the trial, I don't know if the assumption was quite there, that the earlier you intervene, the higher the probability that amyloid lowering is going to affect the disease. But that's one of the takeaways that we began to demonstrate within this population. So you can see here, whether you're looking at p-tau, total tau, or neurodegeneration, your placebo versus your intervention, there is evidence that there was a greater effect in the asymptomatic population if you lower plaques. With solanezumab, there was no such effect across the whole population here. So again, this was reinforcement for us to continue and actually move earlier in the disease. And I think this will end up holding up to, and in fact, that's what we seem to find from the trials with lecanemab and donanemab, is those that are earlier also have a better clinical outcome. When we looked at the data more recently, and this is a paper I hope that's going to be coming out very soon here, and we looked at the different tau, soluble tau peptides. So what you see here is just looking at the early phase tau pathology. So that's 181, 217, 231, 153 versus the later stage tau pathology. What you find here is that, again, what we found is that when we had a change in amyloid PET, so this is using the gantenerumab data, when we looked at the change in these biomarkers with the change in amyloid PET, sure enough, we saw these very strong correlations between the change in amyloid and the change in the early biomarkers, but the change in amyloid was not at all associated with those later tau biomarkers, whereas tau PET was more strongly correlated with things like CSF205, MTBR243. So in here, this was actually nice confirmation of what we thought we were seeing in the natural history, that these early changes that occur with the sort of post-translational effects of tau when amyloid starts to develop were in fact the ones that responded to lowering of amyloid as well. But those ones that were happening later in the disease, this sort of separation potentially, this disassociation, those are the ones that are most resistant even when you begin to lower amyloid plaques. So these maybe become obviously our targets for tau therapy, but these also give us a chance to look at if we intervene in the disease early. We then looked at the data in a different way too here. So, as we think about the longitudinal data, we always plot it over these sort of EYO, how the disease changes. And so again, we then wanted to look at, well, if we look at the intervention, gantenerumab being here in blue, the placebo here in purple, and then our non-carriers in green, do we actually see a stage of disease or a time effect as well? And again, that sort of holds up here relatively well. So if you look here at tau PET, no effect. If you look at amyloid PET, we actually see an effect that clearly is showing up here, and it does look like it continues to separate. If you look at the early A-beta tau-related changes, those seem to change. And then the later ones, however, don't seem to change much at all. But importantly, what this allows us to do too is that oftentimes within the trials, we'll look at a percent difference, right, or a percent lowering of our biomarkers. But what we're really trying to show here is that although we had a significant lowering of amyloid plaques with gantenerumab, you can see how much room there is still here. So even though we're lowering amyloid PET here, if you look at the differences across the EYO from -15 up to 0, for instance, we really want to take this line and push it down this way. And again, within the Downs cohort, when you begin to model out that disease and you understand it, you'll be able to do the same things to demonstrate how well are your biomarkers sort of reflecting the disease, how well are your therapies normalizing things. And so you'll have the advantage, again, of looking at this kind of disease across the time and the staging as well. So then lastly, what we've then recently found is treating early better. This was, again, the assumption, and this is data that some of you may have seen in a recent publication. So what this is reflecting is the long-term exposure from the DIAN-TU study. So this is a little bit complicated, but what we had is because we had this platform trial, we were able to follow individuals at the end of that double-blind intervention. There was a brief period of time, a gap of about 1 year, and then we did an open-label extension. We were able to follow these individuals quite well. And so the thing I want to focus on here is that there was a small group of individuals that came into the trial. They started at an asymptomatic stage of the disease. They were started on gantenerumab, and then they continued after the open-label period. So this is a group that over about 8 to 9 years has exposure to gantenerumab. So this is sort of the longest treated asymptomatic cohort that it was, and then we compared across a number of different considerations here, the SOLA, placebo, and then our matched controls that come from our natural history study. So again, showing the importance of having these links between your natural history studies and Downs, and then your clinical trials, and finding as many of those outcomes and interventions and everything that are similar across that. So what's the important findings of this? Well, when we looked at any open-label participants, so this could be individuals that started on solanezumab or placebo that came into the trial, this was their last double-blind or open-label extension. This is sort of where their amyloid was on the centiloid scale. If we look at the baseline asymptomatic Gantt-treated participants, there again, we see the majority of those actually were below that centiloid value of 25, showing us that this is a group that we were getting much closer to where we wanted to be. And when we compared them, we actually found when you use CDR sum of boxes, and we've looked at this in a number of different ways as well, for instance, a number of different sensitivity analyses, we find evidence that that early treated group, that group that had the longest exposure and started asymptomatically, has about a 50% reduction in progression to that first change in CDR sum of box. So if that first change in CDR sum of box is from 0 to 0.5, that's approximately 50% delay in the onset of symptoms of dementia. So this is some of the first evidence that we have, caveats included, obviously, that early intervention is going to be really critical with the amyloid treatments that we're thinking about. So then how are we using this to map out our clinical trials? This is a little bit busy, but what I want to show, though, is how we then use this stuff to get to what we are now starting with the primary prevention study. So all you're seeing here is essentially a modeling of the data that we got from the natural history study, looking at the probability of becoming amyloid negative to amyloid positive along the EYO. And so what you can find is you can look at your data and the estimated data versus the dots that represent the real data, and then you can plot out these curves of when you think individuals are likely to go from amyloid negative up to amyloid positive. So in our population, by the time you hit EYO -10, it's about an 80% probability. In the primary prevention study, where we're starting here at -25, you have a very low probability of being amyloid positive. So this just allows you also to enhance the cohorts that you're running in, and you'll confirm these, but it gives you this fit. But importantly, then you can use your other biomarkers as well to track different stages of the disease. You can do these fits also. This is 217, looks much more like amyloid PET if you match those, versus 205, which changes here much closer. That 80% probability of being positive is only after you're symptomatic. So a 10-year difference between those probabilities. And we'll see how well these end up fitting. Likewise, when you start to look at the accumulation of biomarkers, you can begin to look at, again, those probabilities starting at -25 in the primary prevention study. This is looking at a number of different biomarkers, including PIB, the 40-40 ratio, p-tau 217, 205, and 181. And you can see this kind of stacking in this progression versus the non-carriers here, where virtually nobody has these abnormal biomarkers except for a few 5 to 10 years after the expected age of onset. So that's what we've been using this to build these disease progression models, where we actually think about using these for the clinical trials. And the long-term approach is that we can actually start to use this to sort of model what does it normally look like as an individual with the mutations, begin to accumulate these. You can see this kind of stepwise occurrence in the accumulation of these. And now we can start to use this model to say, can we keep people who start here the whole time? And the longer we keep people in a specific stage, the higher the probability that we're having a true disease-modifying effect without having to keep them in the trial for 15, 20, or 25, 30 years when we're doing a primary prevention study. So it allows us then to we've then essentially used this to do this multi-stage primary prevention study, where you have stage 1, which is going to be focused on A-beta PET. We use that modeling data that we have along with the information about associated biomarkers, including tau. We then move into this stage 2, preventing this incremental increase or these steps in the biomarker profile. And then ultimately we link the number of abnormal biomarkers to the probability that somebody develops clinical symptoms, and use that to build a case to have clinical trials that can be done more efficiently and in a shorter period of time in primary prevention without, again, keeping people in 10 to 15 to 20 years. So this is going to become increasingly important too with the Downs cohort, at least based on some of the data you were showing, Mike, that the difficulty with recruitment of getting people in, and then you're going to propose to people, we're going to keep you in a trial for 10 years. So think about that for your recruitment aspect. So you have to think about better ways to use these biomarkers early to build a case that you can keep people in the study. So this is just our whole platform. This is the secondary platform starting in 2012. This is the primary prevention study, which just enrolled our first participant in December of this past year and is now up and running in partnership with Eli Lilly. So what is it? This is broadly speaking what we're doing with the primary prevention study, is essentially we have to do these multi-stage trials. And as of right now, given how the disease changes, stage 1 is going to be an amyloid outcome. So these are clinical trials where the outcomes will be strictly biomarkers because there's simply no clinical effect 15 to 20 years before the disease starts. So the higher confidence you have in how your disease evolves, the higher confidence you'll have then to say you're having an effect when you do these trials that are there. These are small trials. 160 mutation carriers are what's required at least to start off with. So this is great as far as recruitment, but it's a clear risk when you think about what dropout does to your trial as well. So you have much less room there to work with if people start to leave the trial. So you have to build these in ways too, just like Mike had mentioned, that tries to bring as much of the trial to the participants or takes into account their preferences as you can within the sort of limits of giving you a valid trial at the end of the study as well. So stage 1 is a 2-year common close study. We're going to be using remternetug, which is essentially the sort of second, the evolution of donanemab. It can be administered subcutaneously, and that's actually why we chose it for this study too. Within this long-term treatment protocol, we can give this subcutaneously for this individuals. We'll do a 2-year common close with amyloid as the outcome, with secondary endpoints that are built in a number of different CSF biomarkers. And then after that, if positive, it moves into stage 2, which is a 4-year open label study, which will use the controls that we have from previous DIAN-TU placebo studies, as well as from our natural history cohort. And so this is complicated, but there's a few things that I do want to mention, though, that we've built into the study again when we think about keeping people in the study for a long period of time. So in this trial, you can come in, you don't have to know your mutation status to start off with, because again, this is something that we have repeatedly talked with our participants about. And at this very early stage of the disease, the trial will enroll individuals as early as 25 years before expected symptom onset, up to 11 years before symptom onset. And there are a number of individuals that, again, they're very much willing to come into the trial, but they still don't want to know whether or not they are a mutation carrier or not. And so that's built in that all non-carriers will automatically be given placebo during that first 2-year period of time. At the open label extension, you'll have to know whether or not you have a mutation. You can make the decision at that time. They'll be randomized 1-to-1, but I think here's one of the important things is that at year 1, we'll have essentially a dose-confirming biomarker endpoint. So we're going in at a stage of the disease, it's very early. We're using remternetug, which we have great confidence has a robust effect on plaque binding, but early in this disease, we don't actually know. And we're using doses as well that are lower than have been used in most of the clinical trials, with the expectation that 1, we don't have to have as high of a dose at the early stage, but 2, we're really trying to maximize the safety of this too. So I think the last thing that we want to do is have things like ARIA coming up early in this trial affecting it. The other important thing that we've done is that 2 years, because it's a common close, for those of you who don't know what a common close is in a clinical trial, all that means is that the time starts when the first person comes in, and then it stops when the last person completes your 2 years. So if your enrollment takes 2 years, the first person into the trial ends up being randomized to placebo or intervention for 4 years. So depending on how quickly that happens, so because of the fact that it may be 2 years for us to fully enroll for this study, one of the things that we've done at 2 years is that once everyone hits that biomarker 2-year point, if they happen to be amyloid positive at that time, we expect about 30% of our population will be amyloid positive to start this trial. They'll be reallocated in a blinded way. So essentially, this is a way for us to work with our participants to say, if you come into the study, if you have a mutation, and if you're amyloid positive, the longest you'll be on placebo is only 2 years. After 2 years, you'll either be going into open label extension, or you won't know it, but you'll be switched to the intervention at that point. And that still allows us to keep individuals who are amyloid negative and that placebo to keep measuring how well the drug keeps people down below that amyloid negative point. But then it also gets those who are amyloid positive on treatment as quickly as possible, and then allows us to actually look at the biomarkers in stage 2 as well. So what this ends up being, this is a little bit busy, but if we think about the tau curves in part 1, we essentially start in this blue box here. This is minus 25 to minus 10, that's where we start. And by the end of the part 2, you can see how these shift. So part 1, you have those who start out here, and if it's a 4-year trial, that shifts that, and when we go into open label extension, you're now in the red box. And so what you can see is that you begin to estimate where people should be, at least on the tau biomarker stage. So starting here, the majority of the individuals will be positive on the early tau biomarkers and negative on the late tau biomarkers, core 1 or core 2. And then by the time we get to the open label extension, we'll have individuals that may be crossing into that sort of core 2 or late tau biomarker phase, and we can measure those groups differently as well when we think about the outcomes as well. So in summary, what I tried to emphasize today is that these biomarker-based clinical trials for prevention are now feasible, but very, very highly dependent on the knowledge that you've gained in your natural history cohorts. The disease progression models provide a guide, but validation is required. And that's definitely what we've found from our first intervention studies so far. And then these completed trials can provide important data to test. And so I think this is one of the things, too, when we work with our pharmaceutical partners that do these large studies in sporadic Alzheimer's disease. It's really critical for us to get not just those primary outcomes, but what are the additional biomarkers that they're capturing in those, and how quickly can we work with them to understand what these therapies do to the downstream biomarkers as well. And then I think this is really critical, is this expansion of targets of intervention, expansion of biomarker outcomes beyond just amyloid and tau-based therapies are needed now. And these are coming up, and these are going to be really critical for us to understand how these therapies are working, amyloid and tau, but then how likely is it that we can really start to hit some of these other pathways and have really good, reliable, measurable outcomes for that at these different stages of the disease. And so I think that's my last slide. I do want to make sure that I attribute all of the people and groups and donors and funders that have made all of this work possible. This is the Knight Family Diane TU Administration and Clinical Operations. We have a tremendous team. It's really such a pleasure and a humbling experience to work with them. And then these are all of our sites that we see globally. And then obviously this goes without saying, but we could not do this in these small populations without a global collaboration, despite what's happening right now. This is critically important for us to continue the global aspect. Alzheimer's disease, Down syndrome, there's nothing woke about these diseases. They're terminal diseases that affect everyone. And so the stronger we can continue to advocate for how important these collaborations are and how we're actually making a difference in people's lives is going to be critical for us to keep the sort of mission moving forward. So thank you. So I think it's just Mike and I. Anyone else want to come up? Juan? Jason? No. Heather? All right, so we'll take questions. Yes.
Okay, so this might be the question of the day, I'm not sure. But, you know, looking at some of the data from the Diane cohort and Mike, what you were talking about with a lot of people screening out because of amyloid positivity, also the need for biomarkers. One, would you think in future clinical trials as we're developing it, we need to maybe go to a different amyloid centilloid load, and what would that be? Or two, should we be using something completely different than centilloid load when screening people for these trials? And if so, what would that be?
Great question. So in the AHEAD trial that ACTC is running, we have 3 arms: placebo, 20 to 40 centiloids, and 40 and above. This is the prevention trial with lecanemab. And initially in that study, we had an 80% screen fail rate based on this cut points. And we then instituted, and this is maybe 3 years ago now, we instituted plasma pre-screening, p-tau217. And now our screen fail rate on PET was, at the end, somewhere around 15%. So clearly, those plasma pre-screeners will be critical in identifying people that are most likely going to be amyloid PET positive. I don't know if amyloid PET is going anywhere. I think it's still going to be necessary to confirm target engagement in some of these small early DS trials. But foreseeably in the future, we could see not having the need, and Lilly is running such a study where you're just using the basis of plasma p-tau217, presumably explaining elevated amyloid, and running them into that trial. I think that's where we're going to head in the Down syndrome population.
And do you think we need to keep the centilloid level at like 25 or other things?
So the ABATE study has a centilloid level of 25 because we designed that trial years ago. And for the ALADDIN trial and HERO, we're much lower centilloids. If you talk to Risa Sperling, she believes that anything over 5 centilloids is predictive of elevated brain amyloid. So the question is, how comfortable do you feel in the validity of your PET scan when your centilloid level is that low? And we're just not there yet, especially with Down syndrome, where, like I mentioned earlier, the tracers have unique binding processes so they look different on the PET scans? What regions of interest do you utilize to determine eligibility? So to answer your question, I think right now probably 18 centiloids is the lowest, and I don't see that changing for a while.
Yeah, and I'll add to that. I mean, it really is very much dependent on sort of your design and everything as well. So, I think Heather's presentation yesterday on the sort of amyloid clock thing, again, if you're running a 1 to 2 year study and you're sort of below a reliable dynamic range on whatever biomarker you're using, you're just like, you're shooting like a dart into the dark, and your outcomes are going to be really ineffective. So it depends on the question you're asking. If you want to do that for a 10-year study, sure, start at centiloid of 5. So Risa's very aggressive with this, but I think it's really hard to show movement in that sort of point for the CS or the amyloid PET. So I think it's going to be dependent pretty much on what you're doing. And I do think that the plasma stuff is going to be really important for screening, undoubtedly, to decrease the screen fail rate. I don't know how much of that right now would make a difference from the data you were showing, Mike. If you still have to do an amyloid PET scan, even if you screen positive on the plasma, is that still going to get people in, or are they still going to say, no, I don't want to do that, versus...
Yeah, I just want to say that a lot of the things that we're doing are defined by the regulatory agencies.
Yeah,
so
yeah.
Ideally, we want to balance what we'd like to do with what we have to do.
Yeah, absolutely. But then I think too, like long term, we still don't know these plasma biomarkers, what the actual effects of the drugs are on them too. So a lot of them show effects with amyloid, but it's probably not like normalizing. And so it becomes an important consideration too when you think about using these for screening versus outcomes and how you're going to integrate that as well.
Eric, I had a question for you. Something that you didn't discuss, but I think is an important topic, is the ARIA rates and kind of the extent of the ARIA relative to what we've seen in LOAD. So I didn't know if you just wanted to briefly touch on that comment.
Yeah, so for ARIA, again, whether these diseases are different or similar or different, and things like differences in what we know in the PATH data that, again, I think was shown again today, that you can kind of go from sporadic to autosomal dominant to Downs, and you have a sort of stepwise increase in CAA and the probability and the burden of that. So one would assume that we would have higher rates potentially in autosomal dominant if we have a higher burden of CAA, but that hasn't been the case in general. What we've found is that our rates were very similar with gantenerumab. And then we're running a trial right now with lecanemab. We'll have to see what that ends up looking like, but that will be important. Now, this is going to be, I think, again, a really critical consideration for the Downs cohort. Until you start these trials, you don't know. But I think with these really early prevention studies, whether it's in autosomal dominant or whether it's in the Downs cohort, knowing what we know about ARIA and knowing the regulatory landscape and knowing some of the concerns that are raised by people who don't really want and advocate for these antibodies, I think there is a really important sort of consideration and reason for keeping these safe as possible early on, not to sort of cause sort of major stops and bumps in the road, so we can kind of go, so whether that's a titration schedule, whether that's using lower doses for longer periods of time, depending on is it a prevention study, is it an early symptomatic study? I think that's going to have to be a really important consideration as well. And I will say just also, Brian, that all of our estimates for what leads to ARIA are very similar to what leads to ARIA in sporadic Alzheimer's disease. If you have microhemorrhages, if you're an E4 carrier, if you have a lot of amyloid and you're symptomatic. So.
I want to circle back to the plasma question a little bit. So obviously, it would be easier if we could just use plasma to screen, if we could use plasma to monitor. I was wondering if either or both of you would be willing to set what your bar would be for feeling like the evidence was sufficient to say, like, yeah, plasma works for screening, and yeah, plasma works for longitudinal monitoring. Like, what would your bar be?
So there's one paper that's been published. There's one that I know of that's in press, and we've done one analysis looking at the Lumipulse and the C2N assays, and the AUCs for all of these are above 0.90. So in terms of enriching a population, predicting greater than 20 centiloids, we're there. The responsiveness to therapy is still unknown, and that's the big question. But if you're going to screen someone and you know they're going to be amyloid PET positive, but you need to know at the end when to stop treatment, in the case of donanemab, you really need to start with a PET scan. Once we have the variants known and responsiveness known to these plasma biomarkers to treatment, then we can think about dropping PET. But I don't see that happening for a while.
Is there another one?
Thank you for your brilliant talks. And just expanding on that question, where does CSF fit in? Because I think this is really critical, isn't it? And drawing on Juan's talk yesterday, how we define the point of amyloid positivity. I think, with our cohorts, it's different depending on the marker that we use. We know the CSF changes earlier, and we know also that the PET changes are so variable between different mutations. So I think there's a real kind of scientific concern about, with small trials using amyloid PET, which shows such mutation-dependent variability, also just because it's such a barrier to research participation, the access to PET in different countries. Do you feel that we're approaching a point where, for new trials, we might be able to say goodbye to PET, or at least put it down the rank of importance?
So the numbers I carry around in my head are from work done by Matt Zammit, where once you hit 18 centiloids, you increase by 8 centiloids per year, and that's a pretty homogeneous, tight variance in that group. The issue with that kind of a study design would be a time-to-event analysis, where you say, we know they're going to increase by this amount, and we're going to try to prevent that from getting to that point. You lose quite a bit of power with that kind of study design. To go then to plasma and to drop PET completely, your variance, as I just said, is unknown, may be greater than with PET. And so for that reason, I don't see PET going anywhere for the near future.
Yeah.
Maybe just PET?
Yeah. So we hear the PID-PET thing for sure, Natalie. So yeah, I think I agree with Mike. But again, I mean, I hate to say this, it just depends on what you're looking to do. So I would love to have CSF in everyone. If you're doing a one-year study and you have 2 outcomes or 2 points where you're measuring biomarkers, CSF is probably great. In the autosomal dominant population, we know that they tolerate that. The Downs cohort, I don't know. If you're doing a study where you require 4 measurements in a 1 or 2 year period of time, that's a lot of LPs potentially. So it still is this balance of the burden, how you think the drug is working, and your variance on your biomarker, and what you can end up getting. So
great discussion, Eric and Mike. I have two questions, one for each of you, on this kinds of points. So, Eric, how did you convince, because we're hearing from Mike about in a primary prevention study to look at plasma markers, especially when there's so much variability that you're already hearing, and to see that as an endpoint. And then Mike, you also brought up a lot of this, and this goes to also both of you too. Eric, you're going to be looking at very young, 25 years, so there's a limited group of individuals. And in Down syndrome, the studies and the points that you're bringing, and if you look at all the studies that you've listed, Mike, it's actually a smaller window. So how do we get people in for both of these kinds of very limited window groups to be really focused to get them into these kinds of studies?
So I'll answer. So just a point of clarification. So we're not using plasma as any of our primary outcomes. We will use them as exploratory and secondary outcomes, potentially more exploratory right now, meaning that we will definitely be collecting these. We definitely plan on looking at the various biomarkers that we can right now, but PID-PET is our primary, and everything will be linked to that one. And then we'll have these other biomarkers, which are all CSF based too, have the greatest confidence in those. Our approach to how do you get people in and focus? There's multiple ways that you sort of can do this. One is, as the data accumulates and we say, hey, we have evidence to suggest that intervening early might decrease the probability of developing symptoms when we normally would by 50%. And that was using gantenerumab initially at very low doses and then titrating up slowly and all this kind of stuff. That's, really important for people to know, wait, these drugs might be working and we need to do these studies to sort of confirm that that's the case. So that ends up being something that I think is oftentimes really inspiring to people. So that's one approach. Two is we built the trial to try to make no gaps in our population. So, if you did a true prevention study, we would only have individuals that had no amyloid pathology at all, but then we would potentially be dealing with like this 10-year gap between that and our secondary prevention studies. And sort of how do you approach that? That causes increased complexities with trial design, but it makes it so you're going to recruit people and keep them in the study longer as well. So we sort of, again, try to meet our participants as close as we can to where they are to say we're treating across, if you were willing to come in and do our longitudinal studies up to 3 decades before, we want to offer you an opportunity for a clinical trial at that point. If you came in 5 years before, or if you came in with symptoms, we want to offer opportunities for sort of that. So I think having, like Mike said, kind of parallel studies wherever you can to try to fill some of these gaps too potentially helps to do that. And then working with the participants, working with your study population from the get-go becomes extremely critical for this. So that's my answer to this.
I would say regulatory constraints is where we're at right now. We have just overcome one of the biggest obstacles, which is the question of whether DSAD is the same as AD and ADAD and late onset AD. And I think that was put to rest now with all the data that's come from DABNI and ABCDS. I think that the ALADDIN study looking at donanemab and the ABATE study looking at an active immunotherapy against beta amyloid, those are certainly things we want to offer. Certainly one is already FDA approved. We must test this and make it accessible to this population. As you think about the ASOs and other drugs that are targeting the genetic basis of Alzheimer's disease in this population, you would not want to wait until amyloid PET positivity. That's probably too late. But in our current regulatory climate, target engagement, safety and tolerability, testing a first-in-human in the population that is further along is in the disease course is where we have to start. But just like with A4 and AHEAD that emerged as moving earlier in the disease course in the general population, and all that goes with the disclosure of, you're eligible for this trial because you have elevated brain amyloid in an asymptomatic person, and all of the processes that go along in disclosing that to someone who's otherwise healthy, and thinking about those kinds of things in the Down syndrome population is where we need to also head in our trials. And until we develop those processes and the regulatory agencies accept those processes, we're going to be at the point of we see disease and we can test target engagement. A 15-year study is not feasible, so we need better biomarkers earlier stages of the disease.
There's a question from up high.
Okay, yeah, I can hear myself now. Perfect. So how are current ADAD and DSAD trials doing with regards to diversifying their samples, the inclusion of traditionally underrepresented populations, and if there's enough of a sample size, have you found any differences in the effects and side effects of interventions?
The NIH designates people with Down syndrome as an underrepresented group, and I think that's very valid. We are trying to engage with the diverse communities in learning about the relationship between AD and DS and being consistent in our messaging across these populations. But there are a lot of questions about trust and familiarity, and those are obstacles that we face in our general population as well. But it's not that we're not going to try, but it's something that we haven't started yet.
Yeah, so for us, we've taken sort of two approaches. One, we still don't know as far as, actual sort of race, whether or not it is in fact the case that these were mutations that generally developed in sort of specific areas, and so you'll be inherently limited with the who has the disease. So we're continuing to sort of expand as much as possible. Ours, I think, has been more of an economic disadvantaged or underrepresented approach in a sense, so making sure that we get to countries that haven't traditionally had the opportunity to participate in clinical studies or clinical trials, and then even within those, identifying individuals that, like families that are in very remote areas that have never been involved in clinical trials, and trying to get them and go to them as much as possible with things like home health networks and things like that to try to expand what's the potential geographic and economic, sort of that social aspect and how it might affect disease progression and onset and resilience. And that's, I think, the major way that we've approached this.
So congratulations to both, great presentations. I have a question about the window of intervention. I think that this is, in all prevention trials, it's very important to see when you intervene, and both conditions are extremely linked to EYOs or age. And for instance, the first question is, what about this combination of pre-symptomatic and symptomatic that you had in Gante? I know that was probably not your choice as design at the beginning, but you were forced to do that. There are some designs that have kept in that path. And so have you modeled the impact when you are, I'm talking about when the readout is clinical, the impact that widening the window in preclinical AD, and not to speak when you include symptomatic participants, has on the design, because we cannot assume as in sporadic AD that it's going to be the same for each subject. So I think the weighting of the subjects, and are there ways that you have modeled it in DIAN, and are there statistical models to factor that in, and that can be in the primary endpoints, or how are you thinking about those things, especially in the context of DIAN, where you cannot be as targeted as in DS, where, I mean, we are facing challenges in recruitment in DS, but in theory you could be more narrow in the inclusion criteria. So what are your thoughts in that direction?
Yeah, so I mean, Jason can answer some of this as well. From the clinical perspective, I mean, so statistical modeling is magic, right? You can model anything and make everything look great, but in reality, when you do the clinical trial, it ends up being not what you expected. So we can model things. I mean, we do a lot of this. So disease progression modeling is critical to us, to the whole field, right? To really link how closely those biomarkers that change right around that time that we think people get symptoms, how reliably are they measured? So that's the surrogate approach, right? Can this biomarker really end up being a true predictor or linked fundamentally to that clinical outcome, so you can use that. But we're not there yet, despite considerations for surrogacy of amyloid PET. The other is, I think, again, trying to come up with better ways of measurement. So that's where Jason comes in. So finding ways of reducing that variance in that pre-symptomatic period of time, to see if you can just get that down so that your signal to noise ratio in these shorter or 2-year period, 3-year period of trials, you have to do everything you can, I would say, to sort of reduce that. So find your tests that are best in doing that. And but the limitation and the problem is a clinical trial is different from your observational data. So it's great for modeling and predicting, but the reality is when you get people in the studies and you expose them to the drugs and to everything else, there's going to be differences in everything too. So you have to end up coming up with these surprises. So then that's a numbers game. Can you expand the study, or can you, again, build in clinical and biomarker sort of together to sort of say, this is a person who seems to be hinting in the right direction on the clinical outcomes, or this is group, but their biomarkers are really moving robustly. I think we should keep doing this and moving in this, this is an interim at this many years, and then go on to the next stage. That's kind of some of the approaches that we've been doing. And then we've been also looking at what are the biomarkers that are most reliable with an asymptomatic group, what are the biomarkers that are most reliably linked to the symptomatic group, and enrolling all together, but then stating ahead of time that we have 2 outcomes for those populations as well. That's another approach that we've been taking. Jason, I don't know if you want to say any clinical neuropsychology stuff. So.
I would add that remember that we're just getting the month 32 visit data from ABCDS, which is looking at many cognitive assessments. And I think the biomarkers, people have a good sense of the rate of change, the amyloid clock NDS, and the great work that Bo has been doing, with the ADAD comparison with DSAD is terrific. But for cognitive assessments and a primary outcome measure for a registration trial, because right now the trials are all phase 1B, very small numbers, really safety, tolerability, target engagement. Obviously, ALAD and donanemab is just a bridge study. I shouldn't say just, but it's really a bridge study into this population for really safety purposes. But there are some assessments that I think in ABCDS show sensitivity to early change. Modified cued recall tests being one of them. And in the sporadic population, 10 years ago, Mike Donoghue developed the PAC, the Preclinical Alzheimer's Cognitive Composite. And the PAC is a composite that's very sensitive to early change as we moved in the sporadic population. I'm not so sure, how we need to develop the outcome measures for the Down syndrome population, knowing that they're all going to eventually develop it. Would something like a CDR sum of boxes that's got some functional assessment involved in the Down syndrome population, designed for the Down syndrome population, be valid from the FDA's perspective is unknown. But we're still in the early stages before we get to that point of discussing cognitive outcome measures as primary endpoints.
I don't know how digital biomarkers didn't just come up during this class. Exactly. So.
I mean, that's a fantastic session, so congratulations to both of you. One aspect I think we didn't think about now is that of course we want to fight heterogeneity in these data sets. That's what kills us or prevents us from seeing effects that are potentially there. And one heterogeneity, of course, comes at autopsy, that you have so many different pathologies, at least in the sporadic AD population, but I think it becomes increasingly clear that Alzheimer's goes beyond A-beta and tau for at least many individuals, and that there's a great variability. So, and of course, one of the problems is we don't have great biomarkers so far to reliably detect them. But how would you build in these concepts of reducing variability to better understand or better predict the potential of co-pathologies for these cohorts, and what do we need to go to get more control about, what do we need to do to get more control about this aspect, or should we just keep not looking?
So, Johannes, I mean, I had the same question just about Downs. I actually don't know the prevalence of TDP-43, the prevalence of synuclein, for instance, in the Down cohort post-mortem. So there's probably some data out there, but I don't know what it is. So and there's people in the audience who know that obviously much better than me. From the autosomal dominant population, again, I don't know, to be honest with you. So one thing is if you're using an amyloid intervention, then I think we should assume that if somebody has multiple pathologies, that it's probably going to have a limited effect on that when you're symptomatic especially. So I think that's one important. If you're using a tau therapy or something, I don't know. What we don't know is, at this point, I think the overwhelming majority of information that we have is from sort of larger late life cohorts that extrapolate clinical and cognitive performance 5, 10, X amount of years beforehand to then multiple pathologies after. And I don't know how well that truly maps onto how much of an effect these pathologies are really having. The effect of TDP-43 and synuclein that's isolated and not diffuse actually seems to be relatively limited. So I'm not as worried about that vascular pathology. I think that's a big one. So if you have white matter changes that are consistent with vascular disease, I think that's a problem. I think we're going to run into issues with that. So this discussions earlier today on the white matter hyperintensities and DTI, understanding what's causing those things, I think is actually going to be really critical. So the easy answer for me is, I don't know, we'll find out as we get more of the postmortem after we treat people and see the effect. But I also I don't want to assume that they are having a huge effect in these forms of Alzheimer's disease versus late life, and I don't know the differences, but I'm not sure. I think having our drugs work better is an easy way to address that, but that's easier said than done.
We published a case report of one of my former patients who died at 72, and she had plaques, tangles, Lewy bodies, TDP-43, evidence of infarcts, cerebral infarcts, and significant atrophy. I think her brain was 720 grams at the end. So the pathology is there, co-pathology is there. But we just did a review of the literature, and we do not see that type of pathology under the age of 50. That hasn't been reported in Down syndrome. We've also looked at vascular pathology, specifically microhemorrhages, and up to the age of 55 in the ABCDS cohort, something like 80% or 85% would be on the basis of microhemorrhage counts being less than 5 would be eligible for our clinical trials in the Down syndrome population. So the prevalence of microhemorrhages detectable by MRI is actually not so bad. And as we know, microhemorrhages don't really exert a huge cognitive influence. So I would agree. I don't think that the co-pathologies are going to play a role in diluting out any cognitive effect of a disease-modifying intervention at a younger age. And the earlier we go in the disease process, the less we'll have to worry about any effect of those pathologies. And I think cerebrovascular disease is probably number one on the list. The other pathologies of protein accumulation are probably much later in life. I'll also mention that there's a number of studies that have shown NFL is a very good indicator of Alzheimer's disease in people with Down syndrome. In the general population, it is not. And there's so many comorbidities that can lead to a rise in NFL. But in Down syndrome, NFL increase is a clear example of really pure Alzheimer's disease in the DS population.
It's reason to advocate strongly for the Downs studies that you all are doing to really connect with your participants about the importance of post-mortem donation as well, though. So I would definitely encourage as much that can be done to support that, to get people to donate their brains after they participate in these biomarker studies is going to be absolutely critical to better understanding that as well.
Yeah, it's really great to see that the therapeutics for Down syndrome, Alzheimer's are now going to be starting and coming out. And certainly having biomarkers to be able to identify the outcomes for that is obviously essential. Are we now at a point of being able to, separately from using biomarkers to help outcomes for the therapeutics, are we now at a point now that we can use biomarkers for people specifically with Down syndrome to now give them a pre-symptomatic diagnosis of Alzheimer's now? Wholesale across the whole Down syndrome community now? Years ahead?
It's a great question. You know, there's availability of these blood tests now. One is FDA approved, another one will be approved later this year. There's, 2 FDA approved treatments out there, and the clinicians, Seth, are asking the same question. And the appropriate use recommendations state that these treatments should not be used in this population until safety studies are done, for good reason. And the diagnostics, they're pretty silent on the use of those diagnostics. The question at the end of the day is for the benefit of the patient and causing no harm. So if the patient, the individual, before they're really a patient, wants to know their risk and their status, then it's worth a discussion and an informed decision about going through and getting that test, whether you have elevated brain amyloid or not in the setting of Down syndrome. And what are you going to do about it? And so those are things that it's an individual's choice, and it's worth having the conversation with the caveat that we really don't have any treatments available yet.
Hi, I have just one comment and one question. One comment about co-pathologies. I think the fact that these co-pathologies are found at the autopsy, really, I don't think they really necessarily mean that they have an effect of cognitive during early in life. And also, I think it's great that some of these copathologies, alpha-synuclein, are downstream of amyloid pathology, so perhaps you can intervene in several of these copathologies. Just one comment. And the other question is, what do you think about other targets beyond amyloid, especially, for example, tau or other specific targets related to autosomal dominant or Down syndrome, and also the data you have shown about these atypical tau pattern, how do you think this could have an effect also potentially on anti-tau therapy? So.
At ACTC, we are getting ready to launch the ATP, the Alzheimer's Tau platform. This is a 6-arm trial which will enroll individuals into a first phase of donanemab or placebo for clearance of amyloid, and then randomize them into different arms with anti-tau therapies. And that's something that we're going to watch very carefully from the Down syndrome perspective and see whether that's an approach that we could take. But I think we have to see how that enrolls and how that moves forward before we can power that study in the Down syndrome population.
Yeah, so in the autosomal dominant population, I mean, tau obviously makes sense to target, but I think we have to be ready for a humbling experience as well. Again, the overwhelming majority of our assumptions with tau's relationship with clinical symptomatology started with BRCA staging, right? And we made these assumptions at the postmortem. And the tau PET scans correlate pretty well with clinical symptoms when they do. But then when they don't, we kind of dismiss that. And the data so far from the Biogen study with the ASO, again, if these assumptions that there was just such a strong link between tau pathology and clinical symptoms, we should be seeing a whopping signal, clinical, like a really robust clinical signal in that ASO driving down tau PET if it's truly driving down tangles. So I think we still need to understand truly what tangles are representing and what they're doing versus how they get to the point of being a tangle and whether there's an earlier intervention. So for tau, I think we need to think broadly as we've been doing with the interventions. Where's the best place to intervene? Is it, again, those tangles versus oligomers? Do you block the spread? Do you remove that? So I think that's an unanswered question. And the broader we can approach that, I think the better off we'll be. As far as the other targets go, it's really hard to predict, right? So in the sense that, yeah, the main ones, so the immune system and the inflammatory system, but again, it's really quite complicated in figuring out how to do that. If you look at the STREM2 data from Elector, it's like really surprising what happens depending on how you intervene on microglia. So I think it's a really important target. Personally, I think, again, how the brain handles misfolded proteins has to be a really critical target for us. So that sort of autophagy, endosomal, lysosomal system must play a role if, the majority of individuals that pass away with Alzheimer's disease have TDP-43, have alpha-synuclein, and they have A-beta and tau. Those are all misfolded proteins, so something's happening within the system that's causing those to aggregate at some point, and whatever's causing that, I think, has to be a really critical target for us as well. So, some thoughts.
Well, I can add from our brain bank, for example, we have checked ADAD patients and Down syndrome AD patients. And for example, from the 20 subjects, or I don't remember, 18 or 19, that we have analyzed, more than 50% of them have Lewy body pathology, but we have 3 of them that are very young and they have very tau stations that are very low. They don't have alpha-syn or TDP-43. And when you check the patients that they have TDP-43, they have in the amygdala, for example, which, how is the contribution of that? And they are in the late, we always say that we look to the photo finish of the patient. So, yeah. And the other thing is that 50% of the subjects that they have that 50% of patients, more or less, they have alpha-syn. Most of them, they have in the olfactory bulb in the amygdala.
Yeah.
There are very little of them that they have limbic or neocortical. They are, of course, but I don't remember, Juan, I don't know, 3, 4, or something like that. And with the AD patients that we check, I don't remember the numbers so well because it was a little bit farther, but they were similar. And they didn't have, they had amygdalar, but they didn't, there were maybe 3 out of 10 or 13, I don't remember, that they had, limbic or neocortical. So, I mean, I don't know, it's in the same line that Alberto was saying, right?
So I think that's fascinating, though. I mean, I think really with the Downs cohort, right, if it ends up the majority of pathology that you have, half have alpha-synuclein, which would line up. But if in almost all of those individuals, it's really focal and limited, yet they have diffuse Alzheimer's disease pathology, that is quite unique from late onset and even from the autosomal dominant population, where we have most of the alpha-synuclein is still in that sort of limbic predominant phase. We have very few that have diffuse Lewy body. But I think that's a really critical aspect. And then they have very low percentage of TDP-43. And when you do really isolate it to the amygdala, I think this is like something we really need to understand better as to why that ends up happening. Again, is it just from the point that you get symptomatic, you do really have a much more rapid disease progression, so you don't have time to accumulate these other pathologies? I don't know, but I think that's really fascinating.
Sorry. Yeah, I agree with you. I just wanted to mention, because you're talking about the photo finish, but DS finished earlier. So I think the survival after dementia in Down syndrome, as we've seen, is 4 or 5 years, whereas in autosomal dominant, it's probably twice that size. So in the line that Alberto and Laura were saying, if we consider that maybe in the disease process, these co-pathologies appear later, I mean, the fact that in DS is more amygdala, a few are limbic, and few are less are, I think that is maybe this extra 4 or 5 years in autosomal dominant AD might account for that, or could be a contributing factor beyond that difference in the biology. So I would consider this difference in the survival after dementia diagnosis too.
Yeah. But if that's the case, that would suggest that these co-pathologies should have very minimal effect on our clinical outcomes, even in late onset or autosomal dominant AD, unless it's really diffuse. Yeah.
Sarah Walter from ACTCDS. Thank you both for your presentations. And what we hear from our participants is that they really want individual research results back. So Eric, I know Mike, I'm chirping in Mike's ear all the time about this, so I know that there's plans underway, but maybe Mike, you could talk a little bit about what information you're planning to share back in your studies. But I'd love to hear what you're sharing, Eric, when people come into studies. What do you tell them about their eligibility? At what point do they have an option to learn their risk biomarkers? Is it at the end of the study? Is there a midpoint decision? Love to hear more about that.
Yeah, so it's a great question, and it's something that we're actually still sort of dealing with and struggling with as to when to introduce those. So I think starting off, there was the confound of if you tell anyone something, then they know that they carry the mutation. And so there were a lot of individuals in our studies at the start that didn't want to know their sort of mutation status. And so that biomarkers are just intricately linked, and so we couldn't reveal anything. And so I think that's continued to influence sort of how we've approached things. It's changed with the clinical trials in that now that we've gone into, in a lot of our secondary prevention studies, you have access to amyloid immunotherapy if you enter the trial. So in that case, you have to know whether you carry the mutation or not, but we're still not giving people the information about like their biomarker status, for instance. I think what we've been really trying to figure out and deal with is, what information does that provide in this sort of form of Alzheimer's disease when you know that if you end up having a mutation, you're going to get the disease. And we as much as we'd like to say, like, if you're amyloid positive, here's where you are on estimated years of onset, and it's likely that you'll develop disease like within this time, it's not so precise. And so we also want to be very careful about saying to somebody, well, your amyloid level is, your SUVR is 2. Well, what's that mean? We don't know. I mean, based on your family history, you're 5 years before we think you should get symptoms, but your amyloid level, does that mean you're closer or further away? And then how do you deal with that information? So we still honestly have been kind of sort of struggling. So we'd be more than happy to actually keep talking with you and others. And we have a lot of input from our participants about this and what it means. And we have experts kind of working on this to sort of help inform us to do this, but we still haven't broadly made sort of decisions on, if you want to know your biomarkers, we'll tell you your biomarkers, because we don't actually still know what that means, and we don't want to over or under promise what that information is. So I think that's where we are. So to me, like if telling somebody they're amyloid positive in the sporadic population, or potentially in Downs, it's different, but in Downs, to me that's equivalent to telling somebody you have, like our families have been dealing with that, like you have a mutation in your family. So in sporadic AD, you tell somebody you're amyloid positive and they're asymptomatic, well, you've just told them you have a very high probability of developing Alzheimer's. Our families are aware of that once they come into their studies, so we're trying to deal with, like, they're already in a sense like amyloid positive with how we think about the general population. So then how do we continue to sort of add to give them helpful information, determinations? So.
Hi. So there's a percentage of people with Down syndrome that are resilient to cognitive decline. We have seen around 10 to 13% in our autopsy cohort that they have end-stage Alzheimer's disease neuropathologically, but they did not develop symptoms. So some of these people will be included in those clinical trials, especially in those that are including asymptomatic individuals. What do you think about including them? Do you think that these treatments will have a detrimental effect on them? Or what are your thoughts?
Yeah, this is a great question. The same is true in the general population with the AHEAD and the A4 study. In that case, we talk about elevated brain amyloid and the risk of developing symptoms down the road. And individuals who show resilience is terrific, but there is an eventuality where we do expect everyone who has the pathology to show symptoms. And that's not a reason to exclude them when they show sign of disease pathology. It would be like someone having evidence of cancer and saying, well, we don't know when that's going to become metastasized or symptomatic, so we're not going to enroll you in a trial. So I think that they should be included, and at least they should be given the chance to be included if they so choose. For the ALADDIN study, it will give us an opportunity, just to Sarah's question, it will give us really the first opportunity to provide results back to participants and their families in the setting of a trial. The disclosure of ApoE status is critical in the general population in relation to understanding your risk for developing ARIA. That's part of the appropriate use recommendations. And so we will be disclosing ApoE status. Positive or negative, elevated or not elevated amyloid on PET will be disclosed to the participants. Their clinical status will be disclosed to the participants. But right now, what we've been developing are the processes for how to develop it and how to assess the delivery of this information with pre and post assessments, things that we did in the A4 study 12 years ago that we're now doing in the Down syndrome population, should have been done 12 years ago in the Down syndrome population, but we're now just getting around to doing it today, where we will have at least our first approach on disclosure and how well did it go over? Did it cause any distress? Because that will help us adjust our processes and improve it in the future. So ALADDIN is really going to be the first opportunity to do that.
I think it's 1 o'clock, so we're getting into people's lunch at this point. So, and it's really nice outside. So should we end the session then? So thank you all very much.
Alzheimer disconnects memories, lives, and families. Every day, millions of people around the world are affected by this disease. But at the heart of this city, a leader in cutting-edge research, a new connection is born. The Hub Alzheimer Barcelona. A unique and innovative research network that brings together public and private institutions, professionals, researchers, and civil society to move forward together in the fight against Alzheimer's. The future of Alzheimer's research begins here. Our Hub Alzheimer Barcelona. Together, we can change the future of Alzheimer's. Contact us to learn more.
Is it live? Are we good? Are we good? Testing?
Perfect.
Okay.
Thank you.
Hello? Yeah, yep.
Is it working? Is it?
Next symposium, which is Making Research Participation Meaningful, Perspectives of Adults with Down Syndrome and Their Family Members. And this symposium idea actually came to us as feedback from last meeting. And I think it really sort of recognizes the growing sort of recognition both in Down syndrome Alzheimer's disease, but also in autosomal Alzheimer's disease, for the need to capture the voices and the perspectives of self-advocates and their families, and to really make sure that we're using that information for our research. So both in terms of thinking about what are the most meaningful questions that we ask, how do we design our studies and our interventions, and how do we use information that we get from our research to give back to that broader community, but also to the specific research participant. Today's panel is co-funded by the National Down Syndrome Society, T21 Research Society, and the ADAD-DSAD study. So we are going to start by hearing from our experts, adults with Down syndrome, their family members, and researchers who engage in a lot of community advisory board work. We will then open it up to questions from the audience, and then we're going to have Dr. Annie Cohen and Matt Janicki come up, and they're going to wrap up by highlighting some highlights that come out of our discussion today. So we'll go ahead and get started. Can you tell us your name and two things? Yeah, go ahead. Oh, they want the questions. Oh, hold on. Well, wait a sec.
Thank you.
We'll get all ready first.
Are they in this notebook?
No, it's in my blue notebook.
Okay.
Oh.
Oh, she's bringing her head back.
We got it coming. All right. So Greta, let's start with you. Can you tell us your name and 2 things about yourself?
I'm Greta Foy. I'm afraid of needles. I'm an aunt of 2 nephews. And it's my first time being here in Spain.
Great. Erica, same question.
I've been Greta's mom for 44 years, and one time I also was a mom to 2 horses, 4 dogs, 3 cats, a pony, and a burro. I'm an animal lover.
We can tell by your list. That's great. All right. Angela, do you want to tell us your name and 2 things about yourself?
Ángela Revueltas Almerón, me llamo, soy la madre de Laia, con síndrome de Down. Cuando ella nació yo tenía 32 años, la síndrome de Down entonces se empezaba a conocer, no se conocía mucho, y siempre he estado con ella para que llegase al máximo sobre su nivel intelectual, de donde pudiera llegar, que llegase hasta el máximo. Y lo he conseguido y estoy muy contenta.
So she's Angela. She's the mother of Laia, and she said that she had Laia when she was 32 years old, and by that time they didn't know that much about Down syndrome. And she said that he's been doing the greatest efforts for her child to do the best that she can, based on her level of intellectual disability, and she believes that he has achieved that, and she's very proud of her daughter.
Me llamo Eulalia. Estaba de vuelta. Y sobre mí, pues, me encanta mi vida. Hago muchas cosas con la fundación que estoy. He podido tener un trabajo en el actual. Una fundación, Fundación Aura. Gracias a ellos he podido trabajar y bueno, y también tengo otra actividad. Puedo salir de fin de semana o a veces se llama Fundación Ludalia, de la luz de gas. Y a veces voy a actividades de Ludalia y hago muchas cosas con ellos. Y estoy muy contenta, de verdad. Y tengo 38 años y haré 39 en julio. Y bueno, soy muy participativa. Me encanta participar con todos vosotros. Y bueno, yo he querido participar en este estudio porque primero quería y soy una chica muy participativa, quiero hacer más cosas importantes como esto. Bueno, porque me gusta y porque me siento bien. Entonces, pues, mira, me gusta hacer mi vida.
So her name is...
You're good.
Yeah? Okay, so her name is Laia. She's 38 years old. And the first thing that she said is that she loves her life. So I think that's very cool. And she's with the foundation and several associations such as Aura, sorry. And she said that she's able to have a job, and he's working actually, making her money. And she does a lot of activities. She goes out during the weekend, and he loves to participate in studies, and she defines herself as very participative, and she's very happy to be here.
My name is Dana Shulo, and I'm the manager of health programs at the National Down Syndrome Society. I also have a 32-year-old brother named Anthony who has Down syndrome.
I'm Sarah Walter. I'm a researcher at the Alzheimer's Clinical Trials Consortium, Down Syndrome. And one thing about me is my favorite part of my job is working with this population, with this group of people. It's been an incredible experience. Very grateful.
Wonderful. All right, we're going to start with our second question. I think I'm going to start this question with Laia. Tell us about your experience with research on Alzheimer's disease in people with Down syndrome.
He estado participando en estudios de aquí hace unos cuantos años y me ha salido todo muy bien, hacer muchas pruebas, me ha salido muy bien, me han dicho que le ha gustado mucho cómo he participado y bueno, y ahora estoy aquí.
Has participated in a lot of studies, not only in the Alzheimer's Down unit, but also in many other studies since she was very young, actually. And she participates also in a ADAD-DSAD study right now. And she likes to participate, and basically she said that she's now here.
And Greta, how about you? Can you tell us about your experience with research on Alzheimer's disease in people with Down syndrome?
Being involved in the BATE study and also in information first.
Wonderful. And Dana, from your experience, have you had any involvement in research, either as a family member or from the perspective of your brother, Anthony, with Down syndrome?
Yeah, so we are lucky enough to be a part of Dr. Raffi and Sarah Walters' research partnership group, where we can advise on materials and protocols. My parents also participate on that. So it's been wonderful and a really cool way to dip a toe into participating in research.
Wonderful. And Erica, I'm going to start with you for this question. From your perspective, what types of research would you be most excited about to see in this field?
I'd be most excited to see her participate in a study with a therapy or drug that already has a high prospect for either delaying or removing the symptoms of Alzheimer's without any excess side effects.
Great. And Angela, I'm going to ask you the same question. What type of research would you be most excited to see in this field?
Lo que más me gustaría es lo que se está haciendo ahora sobre el tema del Alzheimer, porque es una cosa muy importante a medida que se van haciendo mayores, y esto es una cosa que me preocupa. Es lo que más deseo que se pueda investigar a nivel médico.
So basically, she had the same answer. She's saying that what she really wants to be studied is Alzheimer's disease in Down syndrome. So exactly the same.
Great. Greta, let me ask you that question. What types of studies do you want to be part of?
All different types of research studies.
Are there any you'd be especially excited about?
None that I can recall.
Okay, fair. Laia?
¿Qué es lo que más te gustaría que se investigara ahora mismo en las personas con síndrome de Down? ¿Lo que más te gustaría? ¿Estudios?
¿Lo más que me gustaría?
Sí, que se investigara ahora.
¿Que se investigara? Pues me gustaría investigar contra el Alzheimer los resultados que quería investigar esto a fondo de todo, qué pasaría y que se encontrara algo que se puede mejorar.
She had the same answer as her mother. She really wanted Alzheimer to be studied and to have, to improve that as much as possible. And she also mentioned that she would like to know the results of the studies in general.
Oh, that's great. And Dana, maybe I'll start with you for this question. From your perspective, what types of studies would you be less interested in being a part of?
I think a study that didn't take into consideration schedules would be really difficult. As a sibling, I think you're often worried about parents, and especially if you're at the age where you're considering an Alzheimer's disease-related study. You may be worried about your own kids, your own full-time job, in addition to your sibling. So I think scheduling is huge when it comes to participating in a study.
It's a great consideration. Erica, how about from your perspective? What studies would you be not excited or not interested in being part of?
Well, along the same lines of Dana, things that are, it would have to be like laid out in advance, the time that was involved, and the time requirements. I also have concerns about the invasiveness, especially spinal tap. I know that's not what you call it, but that's what I think of it as. And I think that there should be sensitivity training, especially for the imaging technicians, because we had a sort of negative, not terrible, but a negative experience with an MRI technician when Greta was in the beginning of the ADAD clinical trial last year. She did not end up qualifying because she didn't have enough amyloid. But we had a couple of MRIs, and one of the technicians was pretty unpleasant.
Okay. Well, I'm sorry for that experience, but thank you for sharing. I think this is exactly the type of feedback we want and want other researchers to hear about, so we can think about solutions so that doesn't happen. So thank you for sharing that. Greta?
The debate study took a long time and got myself and my mom both flustered.
And can you tell us a little bit about what made you feel flustered?
Waiting forever. It took forever.
That the study visit itself took forever?
Yes.
That you were there for a long time?
Yes.
Okay. Understandable.
And plus, we had to get back home and make dinner.
So it took a lot of time and was tiring and kind of interfered with schedule, and then you had to go home and make dinner.
Yes.
Yeah. Okay.
The first day was like a 5-hour intake.
Long.
And
Yeah.
that was long.
That was long. Okay. So this is good feedback, thinking about ways we could break things up more, right? I love this. Okay. Angela, from your perspective?
Cuando hay estudios sobre síndrome de Down, todo, o sea, no, a ver, problemas en sí no. Ahora, unas sesiones un poco largas, no me gustan que las sesiones sean poco largas. 45 minutos, 1 hora, sí. Y luego todo lo que se hace tema de pruebas, como se lo hacen directamente a mi hija, es ella la que decide. Y ella es la que si se tiene que quejar de algo es ella, porque ella es la que le hace las pruebas y ella lo sabe analizar muy bien.
So what she said is that what she doesn't like is when studies are too long. When, for example, like cognitive evaluations are too long, so she's saying that 45 minutes is okay, but longer than that can be a little bit too much. And also the type of tests that are performed in her daughter. She said that her daughter is the one who decides which type of test is she going to undergo, because she knows very well what can she tolerate or not. So that's totally on her daughter.
That's great. So Laia, what else would you add from your perspective about studies that you would not want to be part of?
Vale, lo que no me gusta estar de la prueba de lumbar, ¿vale? Porque me ha dado, a ver, ¿cómo lo digo? La verdad es que no me gustaría hacerlo otra vez, en la prueba de lumbar. No porque me ha dado problemas y porque es mi espalda, ¿vale? Y no podía levantar pesos ni nada y estaba, bueno, porque me hacía mucho daño y no podía soportarlo. No podía soportar y entonces pues he dicho, mira, ¿sabes qué te digo? Que no voy a hacerlo nunca más. O sea, que no insistáis para hacerlo y os lo diré miles de veces que no lo soportaría, no. Las sesiones que he estado haciendo las pruebas, las sesiones, es demasiado largas, para mí demasiado largas. Esta vez he estado haciendo los ensayos. La prueba de la relación transmagnética era casi tres horas y no lo he soportado, la verdad. Estaba muy quieta, eso sí, pero más de 3 horas no lo podía soportar.
She said that the lumbar punction was the thing that she liked the least, that it was painful, that she had some troubles, that's what the mom mentioned, and that she was in pain within days, and that she is not going to do that anymore. And the second thing that she mentioned was when the evaluations are too long. So they are kind of in the same line. And she also mentioned that last time when she was doing the neuroimaging, she was there for 3 hours, and that was too much.
Now, Sarah, you do a lot of work with community advisory boards in this area. What feedback do you hear about in terms of aspects of studies that families and adults are really excited about, and what concerns do they bring up?
Well, thanks again. And again, I'm just really grateful to be here. We have a really wonderful partnership group with 6 self-advocates and their parents, and so grateful to Dana and Anthony and your mom, Kay, for being a part of that group. There's people in the group that are not in trials, which I think is really important for any researcher to be listening to people that have considered studies, decided not to join studies, or people that have never considered studies but are still willing to give us that feedback. So I really want to encourage everyone to keep your vision wide and make sure you're talking to the community and meeting them where they're at. So last summer we had a session with them where we just asked them, what questions do you have for researchers? And they have research questions that we need to prioritize. Self-advocates want to make the best health decisions so that they can age well with Down syndrome. So one question came from one of our self-advocates that was really struggling with her period, with her monthly, and she was trying to decide if she took action about that to improve her quality of life now, would that increase her risk for dementia? And that was a question that we can't answer yet, I think, based on the data we have, but I hope that someone in ADAD-DS is looking at that information, because people are aware of their risk, but we can learn so much from the studies we're doing now to help them make the best possible decisions. The other big question I know is limited by data, but from one of our members who's African American, she asked, what data do you have on the relationship between race and Alzheimer's disease?
and Down syndrome? And our answer was, we don't have much. I was really excited to see Dr. Rubenstein's data from Medicare and Medicaid. That's real world data. It's something, it's a start. So hoping to hear more about what we can learn from that data. Those are 2 examples.
Thank you, Sarah. That was great. Dana, from your perspective, both as a family member or thinking about Anthony, what information would you want to know before you would decide whether or not you guys felt like it was best to join a study?
Yeah, I think the health risks are number one. I've grown up and my parents have raised Anthony where we're always looking out for him and protecting him. And this would be no different. I'm sure we would all 3 put our kind of mama bear hats on and want to protect him from any harm. So it would be really important to know what the risks are, if the outcomes are worth the risk in our family's personal opinion. And I think what Anthony would be getting out of it too would be something that we would consider. Is there any benefit to him? Will he receive any medical care that he would not otherwise receive? I think things like that would be the most important for us to know about first.
Thank you, that's great. Greta, what kind of things do you want to know before you would decide to be in a study?
Make sure you have the information. And wait for the results if you have your phone with you.
Gotcha, that's great. So you would want to get some results?
Yes.
Okay.
But it's time have your phone on and charged so they can call and give you the results.
That is an important step. Make sure you have your phone charged. Okay, I like it. Erica.
I'd like to know if your family member participates in a double-blind trial where they don't know if they're getting a placebo or not, whether that would put them sort of at the front of the line to getting any drug that is subsequently approved. Also, I would want to know, is the drug that's being, or whatever treatment that's being studied, does it really have a real chance of providing a significant either benefit as far as not just extension of time to onset, but quality of life? Because if you're going through a 2-year study for a possible 6-month benefit, and depending on what the side effects and how much of a benefit, I'd kind of want to, I know that's kind of vague, but I kind of want to know the risk-benefit trade-off as far as quality of life and length of time that the onset might be delayed.
And this kind of, I think, relates something back to what Dana mentioned. Can you speak a little bit about what would you be looking for quality of life? What, and Erica, actually, let me ask you this first, then I'll follow up with Dana. When you would want to know, is this going to make Greta or my own quality of life, what would that look like to you? What would be better quality of life?
This probably sounds unrealistic, but just an extension of the way things are now.
Okay.
Yeah.
And Dana, you kind of got at that too with Anthony. What kinds of things would you be wanting in terms of the benefit for Anthony?
Yeah, I think looking at, I know I mentioned this, but just medical care that he might receive during the study that he wouldn't otherwise get, I think that could be a big benefit that not everybody thinks about or considers. I think that would probably mean the most, but of course I agree and would love to have some quality of life and extending measures as an outcome of the study.
Thank you. And Laia, what kinds of things would you want?
¿Qué querías saber?
Sí, ¿qué querrías saber antes de empezar?
Bueno, quería saber, antes de empezar en un estudio, bueno, unas cuantas cosas. Quería saber, antes de empezar, si tardaré mucho a hacer las pruebas, cuándo tardarán, si tengo que esperar más horas y también quiero saber a qué hora, a qué día tengo que estar, claro. El horario. Quería saber primero el horario, que primero tengo que saber qué me harán y a ver qué tipo de clase de estudio que me harán, claro. Porque soy yo la que participo, claro. Y quería saber esto. Y bueno, y también quiero saber en qué estudio estaría. ¿Vale? Si participo, pues sería saber qué clase de estudio escoger. ¿Sabes? Primero que me interesa es saber qué estudio hacéis. ¿Qué tipo de estudio? ¿Qué hacéis? ¿Qué contiene? ¿Sabes? El tipo de clase. Eso.
So she said she wants predictability. So she wants to know how long she's going to be, how much time it's going to take, which test is she going to do, and what's the purpose of the study, right?
Angela, how about you? What information would you want to know?
Antes de empezar un estudio, me gustaría saber la finalidad de este estudio, si es para mejorar o sea, lo que se estudia, si por ejemplo se estudia, por decir algo, el tema cerebro, pues si es para mejorar el cerebro, si se tiene que conseguir una buena medicación, saber si se va o sea, una vez se hayan hecho los ensayos pertinentes, si se va a aplicar a todas las personas con síndrome de Down. Y después el resultado de este estudio, que me dijeran cuando termine el estudio que no me preocupe, que lo sabré el resultado cómo ha ido, porque ha participado mi hija en un par de estudios y no hemos sabido el resultado, lo hemos sabido después con el tiempo.
So I will start with the end. She wants to know, she's saying that she would like to know the results, if she will ever know the results of the study, because she's participated in a couple of studies that she didn't get the results, and I think she said that she thinks this is very important. Also, what's the purpose of the study? What are the aims of the study? Explain it in a language that they will understand. So, for example, she mentioned if they are studying the brain of people with Down syndrome, what's the purpose of that, or if it's a new drug. And then also the long-term applicability of the study itself. So, for example, if it's a new drug, if everyone with Down syndrome is candidate for that. Yes.
Okay, that's great. Well, on that topic, this idea of wanting to know information back from a study about what the study found overall across everyone, or wanting to know something specifically about you and your participation, what are your thoughts? What are your preferences? What would you want to know? How would you want to get that information? Let me start with you, Greta.
We'll get the results by a professional doctor, of course. If not, someone in a doctor's office can give you the results, or just make sure that the doctor gets the message so the doctor call you the results.
Got it. So the doctor, maybe even connecting with your doctor, making sure they get those results. And it sounds,
Yes.
okay. And it sounds like you like the telephone.
Yes.
You like people, all right. Erica?
I would just say that also I would like to have direct contact with the people that were in charge of the study, not some underling who just gives you a quick message afterwards. Yeah.
Okay. And time to maybe go back and forth
Yeah,
and
exactly.
ask questions.
Have a dialogue.
Okay.
Right.
Angela?
Los resultados del estudio me gustaría o bien por escrito, digamos, bien explicados, con un lenguaje que no fuera solo médico, sino un lenguaje coloquial, para que lo pudiéramos entender. Me da igual que fuera escrito o por email, me da absolutamente igual. Pero el resultado sí que es muy importante, sobre todo para las personas que participan en este estudio. Cuando acaba el estudio, sea 4 o 5 años, el tiempo que necesiten, pero saber el resultado, si ha salido positivo o por desgracia, pues no se ha podido hacer nada por lo que han explicado ellos. Y ya está, nada más. Me da igual el sistema, pero eso sí, también en un lenguaje coloquial, que la pudiéramos entender, no solo al lenguaje médico.
She said like 2 important things. One is that she doesn't really care how they get the results, even if it's in an email or with a phone call. It doesn't really care about it, but she wants to know the results of the study, especially if she has participated in that study, and in a light language, so in a way that it's a family-friendly language and not in medical terms. And I think another important thing that she said is that she doesn't not only want the results from the study when it finished, but also like a long-term information on that. So for example, if there's another study that has been done and there's like more data on that, to get like an update.
Okay. Great.
¿Qué es lo que te gustaría saber cuando termina un estudio de los resultados y cómo te gustaría que te los explicara?
¿Qué me gusta saber?
Sí, de los resultados.
De los resultados.
Sí.
Pues me gustaría saber después del resultado. Pues quería saber que después después del resultado quería saber si se puede entender un poco de a mí me da igual los tipos de lenguaje, pero es como dice mi madre, o por email o por escrito, lo que sea, me da igual. Pero también, para mí, también me gustaría poco a poco entenderlo, poco a poco para que yo me entienda, ¿sabes? Me cuesta un poco de entender un poco, o sea, un poquito más de una letra más, no sé, más, para tener más fácil de leer, ¿sabes? No con letra pequeña ni tan pequeña, pero que se puede entender también en otro lenguaje, que se podría entender un poquito más cerca. O sea, para atender, digamos, poco a poco quiero atenderlo porque a veces no entiendo lo que me ponen. Y claro, quiero intentar entender lo que quiero entender un poco más. Bueno, soy un poco. Me cuesta entender las cosas, ¿sabes? Me cuesta. Y como me cuestan, pues las letras ¿vale? Me cuesta a veces atenderlo, cosas. Y claro, quiero entender más fácil, o sea, más o menos lectura fácil.
¿Te gustaría que te lo dijeran por teléfono también?
O por teléfono, o por texto, o lo que sea, me da igual a mí. Pero el lenguaje cordial, más explicado, ¿sabes?
So she said that in the line of her mom that she doesn't really care about how she gets the information, but she wants the information, and I think this is also very important. She said that if he gets the information via email, she wants it with big letters and few words, so she's able to understand it, because it's hard for her to follow regular emails or long emails or with a lot of words, right? So few words and big letters.
Dana, how about you?
Yes, I've talked to my brother about this, and we both agree that we would want at least the opportunity to get results back. I think having them in a written form would be great in addition to speaking with someone, being able to ask questions. I prefer to have something written that I can take a look at and then have a follow-up call would be fantastic.
Great. Sarah, from your community advisory board work, are you hearing other messages and things that we should keep in mind?
Well, along the lines of what everyone said, people with Down syndrome and their families have very busy lives, and they are, some of them working full-time jobs. So flexibility is really important. I know in some of our studies we require in-person visits in order to learn risk information, but that can be a real barrier for some families. So they've asked us to consider video or telephone or in person and really give that choice to the self-advocate and the family. And again, always providing something in writing afterwards. That's really important. If any of you have had a tough conversation with your doctor, you walk out of that office and you don't remember anything about what that conversation was. So really important to have something in writing so that you can then follow up and make sure there's an opportunity. Again, as Dana said, researchers should be calling 3 days later or 5 days later to check on the self-advocate, to check on the care partner, and that extended care network, because everyone has multiple people involved in supporting them and helping them with their daily lives. And some people may have a harder time with information than others. Other questions could arise as the more conversations that you have with family and care partners.
And it sounds like also making sure that language is at a good reading level, big font, not using all of these difficult medical terms that are not accessible to
Pictures.
most
Yep.
people. Pictures. Great. Well, we want to now invite our audience to ask questions of our experts here.
In closing, we need to find a cure for this before it's too late.
You're here. Absolutely. All right, we have some questions in the front here.
So this has come up, and I'm kind of curious on your opinion of it, with sharing and getting results back. If, for example, it was a positive result, let's say we learn you're not at risk, would you still want to talk to a doctor, or are you okay just getting that information maybe via an email or a phone call, kind of saying, okay, we don't think you're at risk at this time, or do you think at that point you would still want to sit down and have a meeting with the doctor to talk about that more?
Does anyone want to respond to that?
I'll respond. I think I would want at least a phone call, but probably a sit-down, the information over the phone, and then go in and time to digest it and sit down and talk about it. In our case, we got a phone call that Greta did not qualify for the study, but the phone call and discussion was just a few minutes, and we had already devoted probably 20 to 30 hours into the study. So it just seemed a little off kilter, the amount of time that you invest. And I know there's a lot of behind the scenes work, but just a 5-minute phone call back, it just kind of leaves you a little bit up in the air. Yeah.
So in that scenario, you would have wanted to sort of come in, get more of a
Right.
chance to ask questions,
Right.
or get a little bit more information from
Exactly.
that give that you guys gave. That's great. Anyone else want to respond to that? No. Okay. Sarah, do you
I
want
can share that, we know that not everyone's going to be a good fit for clinical trials. And we know that people with Down syndrome are very motivated to be in research. So I think there's a real need for researchers to take care of your screen fails. Even if you're just not eligible for a study, it feels, when people talk about what that feels like, they use words like, they didn't want me. They don't say, oh, I didn't qualify. They say they didn't want me, or I was rejected from the study. So that's pretty strong language, and we don't want people walking away from research with that kind of feeling, and we hope to have more studies soon that everyone can be a part of. So I think that's really the challenge, and I just want to share, I don't know if it's okay, Greta, but you're an example of somebody that is doing more than just being a participant. You actually are a consultant for your research team. Do you want to talk about that at all? Because I don't think you brought it up yet.
Do you want to do your slides now?
Now is the perfect time.
Now's the perfect. Okay, can we cue the slides, please? Do you want this?
I'm on the KCDD council. I'm one of the new members of the thing.
You can also see him there if you want. I cut him up for you.
Oh, even better. Thanks.
Okay. So do you want to do the slides or do you want me to?
Let me do this. Yeah, it's back.
Okay, so just press the green one when you want that to go.
About me, my community, employment, and being independent. Priorities: aging with IDD, Alzheimer's and dementia awareness, nutrition and staying healthy, women's health, importance of regular checkups. About me. Born January 27, 1981 in New Bedford, Massachusetts. Had heart surgery when I was little. Moved to Florida and spent my childhood to early adult life there. I lived on my own for 15 years in Florida. Moved to Kansas City in 2021. I'm proud of myself on having great customer service, and I love to help people. I love to volunteer to work with little kids, and I help at Help Heart Children's Hospital Daycare Center. I love being an aunt. I have 2 nephews, one's 4 and one's 1. My community, employment. Employment is important because it gives me a purpose and I can help others. First job was vacuum shoes in the late 90s. I wanted to work in the school system, but they wanted me to be EPR trained. I am now. Worked at the grocery store. I worked at the movies and Publix and Bailey store for almost 2 to 3 years and 20 years in Publix. Moved to Kansas City where I worked 2 jobs as well as served on the Kansas DD Council. I currently work at Down Syndrome Innovations as administrative assistant. And at KU Alzheimer's office in clinic in the lab as a research consultant and research assistant to Dr. Lauren Tomey. From my community, being independent. I like to be independent. I lived alone for 15 years in Florida. I cook for myself and follow a chore list. I help pay the bills and balance my checkbook. I make a grocery shopping list, and I'm always on time for work. Of course, I hire people for things that I can't do or don't like to do, such as deep cleaning and plumbing. Priorities for aging individuals with ADD. Alzheimer's and dementia awareness. I have a friend who has recently diagnosed with Alzheimer's disease, and she has Down syndrome, just a little bit older than me. I want more people to know about the signs of early onset Alzheimer's and dementia in people with Down syndrome and other ADD. I have been tested, but tested negative, and I want others to get tested too. Does your state's plan on aging include information about this? Nutrition and staying active. I think it's important for older people and specialized with ADD to prioritize eating healthy and staying active. I'm on Weight Watchers. Almost lost 30 pounds.
Congratulations.
At KU study, I am working on this related to fitness and the relationship with Alzheimer's and Down syndrome. I want people with my age of ADD to go to the gym and watch their weight. What is your state doing to prioritize nutrition and staying active for aging individuals with ADD? Women's health. I'm on the committee on this subject for the council. I am working on a women's health guide for KCDD. I think it's important for women with ADD to go to a doctor for a checkup every year and get the same cancer screenings that women without ADD get. Find a doctor that makes you feel comfortable with. What are you doing to raise awareness about women's health and reproductive health for adults with ADD? Thank you.
That was wonderful. So clearly, Greta is a very busy woman. She has got lots of jobs. I want to go back. I think, Heather, you had a question for our panel.
First off, just a tremendous thank you to all of you for sharing your perspectives and experiences as either a research participant, hearing about research opportunities, working in the research space, and even more broadly around a little bit about each of you. I think that helps in the larger conversation. You all are obviously very more informed than maybe many in the community. And so a question to each of you, if there's time, how would you, imagine you aren't as familiar with the research opportunities or have the connections to your healthcare provider. How would you want to hear about new clinical studies that that may be of interest to you? Or how would perhaps friends of yours in the individuals living with Down syndrome want to hear about research opportunities or research studies? And is that only at the doctor, other opportunities, other places?
Maybe Laia, do you want to start with? Oh, do you wanna- go ahead.
Me gustaría que os llegase la información sobre nuevas oportunidades para participar en investigación, en estudios, a través del médico, a través de instituciones. ¿Cómo os gusta que os llegase la información?
La información para participar en estudios, bueno, hasta ahora me ha llegado muy bien, es a través de la Fundación Catalana Síndrome de Down. Es la información que me ha llegado, siempre ha sido así y me parece perfecta.
So she's saying that the information has been through the Down Syndrome Catalan Foundation and has always been like that, and she finds it phenomenal.
Laia, have anything to add?
¿Cómo te gustaría que te llegara la información de nuevos estudios para participar? ¿Cómo te gustaría que te lo dijeran? ¿Quién? Sobre nuevos estudios, oportunidades.
Pues me gustaría que me llegasen información sobre la Fundación Síndrome de Down. Con mi correo también, pero desde la Fundación Síndrome de Down, eso sí.
She's saying that she would like to get that information through the Down Syndrome Catalan Foundation. It's fine if it's via mail, but always with the stamp of the foundation, so she knows that it's trusted.
That's good. Dana.
Yeah. So I think I agree with Lila. I think hearing through big organizations that people already trust can be a great way to learn about studies. And I'm not just saying that because I'm from the National Down Syndrome Society, but I do think that we can play a big role in sharing information, given our reach, all of the national organizations and even local organizations too. Showing up to events like buddy walks. I think getting to meet researchers in person can be a really cool opportunity for our community and demystifies and makes it a lot less scary, I think, for some people.
Great. Erica?
Now we're really well connected with the Down Syndrome Innovations Group in Kansas City, but there wasn't much information or any community groups in Florida where we lived. So during those decades, we both were members of the National Down Syndrome Congress, and we got their quarterly newsletter, which was awesome and jam-packed with info. And we went to 15 different Down syndrome conventions and got a lot of information there. But we haven't gone in about 10 years because after a while, they're kind of all the same.
That's great. Greta?
And plus, I think early or late 90s, a friend of mine, a close friend, of course, his real mom had put together a Down syndrome, some kind of a parent edition, and my parents were members.
Cool. So that was
But he is not with us because he died with advanced breast cancer.
I'm so sorry to hear that. So you guys were connected with a lot of Down syndrome organizations, though, it sounds like, through parent groups or the
not
national?
so much. When they were younger and like elementary and middle school, but it kind of dwindled off after that age. So that's why I became more involved with the national group.
Okay, great. Thank you. Any other audience questions? If not, I can go ahead and invite Dr. Annie Cohen to start. Do you want to start with yours, and then we'll have Dr. Janicki? Okay, go for it.
So I just want to start by saying thank you so much to this wonderful panel. It was so wonderful to hear from all of you, and I think I learned an awful lot, and I hope everyone else did as well. So I was asked to think about 3 key takeaways from the panel that we heard. And the first one that really came to me from this conversation is that the research that we're doing really should be a bottom-up process, that we should be starting to engage the community at the point where we conceptualize our ideas and ask the community if those are our priorities. And having these voices in the room as we decide on our priorities, as we decide on our design, have someone remind us that a 3-hour neuropsych protocol might not be the best idea, or for me, a 2.5-hour MRI scan might not work for our participants. Sometimes researchers really need to hear that. The second takeaway that I really felt was important from this conversation was the idea of both accessibility for our community in our research studies and the give back that we provide for our research studies. So thinking about things, and Dr. Raffi did a great job talking about this morning, thinking about things like streamlined protocols, being upfront and transparent about the timing of a study from the beginning of the recruitment process, training your staff to work with participants of a whole variety of abilities. Often we don't think about things like MRI techs. That was something that I was really, really troubled to hear about, that an MRI tech wasn't aware of how to best handle imaging of a person with Down syndrome and wasn't supportive of you all, and it was a negative experience. Likewise, the results disclosure and the long-term benefits that we should be thinking about and talking about with our research studies. I thought one really compelling and important thing that you all mentioned that was something that I think I sort of was like, duh, when I heard it, but also not something that we talk about a lot, which is the actual quality of life outcomes. So really taking the scientific measures that are important for our trials and our research studies, but being able to translate that information into what does a reduction in CDR mean? What does a reduction in or an improvement in memory function mean for overall quality of life of individuals? And sometimes that might even be, as someone on the panel mentioned, it's the status quo. It's maintaining the very full and positive lives that these individuals have right now and maintaining that for a longer period. And then the last thing, which I have written down in my notes with exclamation points and lines under it, is respect. I think one of the themes that I heard about all of the negative experiences or the potential for negative experiences all really drills down to a lack of respect in a variety of ways. A lack of respect for the time of the community. We've talked a lot about how these are busy, engaged people, and we should have respect for their time and the value of their time. And again, that's being upfront about how much time our studies take, why they take that much time, why that amount of time is necessary. We also need to have more respect for the knowledge and lived experience and expertise that our communities bring to the table, and engage with that respect for their knowledge in designing our studies. Respect for our participants' capability. I think this is something that really has come through to me, is that our participants may not be able to read a standard informed consent form the way the lawyers told us to write it, but certainly if the informed consent is written in a way that's accessible to the participants, that's meeting them where they are, there's not going to be a barrier to understanding. We need to meet individuals where they are and have respect for the capacity and capability of these individuals. And I thought there were some really great examples of that. I had never thought of the larger font, for example. That was a really important thing in addition to plain language. So I would just close with the importance of presuming competence in this community and presuming that we can do these studies, we can do them with members of our research team who are adults with Down syndrome. The research protocols can be done in adults with Down syndrome. I think many of us in this room remember when we were all told that we weren't going to be able to do MRI and PET in people with Down syndrome. And now we know that we're more than capable of doing that. And the community is more than capable of doing that. So I think if you take one thing away from all of this, that's what I would do.
It's hard to find Annie. She did a wonderful job explaining things. Matt Janicki here. I'm with the University of Illinois at Chicago and also part of the National Task Group on Intellectual Disabilities and Dementia Practices with my colleague, Seth Keller, who's standing there and taking pictures. Our organization basically is looking after the interests and advocacy areas of people who have intellectual disabilities, developmental disabilities, and also dementia. So we're kind of unique in the States. And we have some connections overseas as well, so we're pleased to be here. I'm looking at this from a different perspective. I guess I'm thinking about an administrative perspective. And a question for you is, how many of you have ever participated or been a participant in some kind of a study? I mean, I remember when I first entered my baccalaureate studies and I was involved in a psychology lab study, and I went through that and experience being a subject and other times having other times. And it's something that kind of brings to mind what you go through as a participant. And I think it's good to have that in your framework as you begin to design, working with others that you're going to recruit to be in studies. Most of my studies I've been involved in have not involved direct relationship with people. We've been dealing with data analysis, so we're a little removed from that, but I appreciate what you go through. I have sort of three things that I thought would be useful in context of what you just told me about your experience with being studies. One is the advocate focus. I think you have to realize that you got to have people that are working with the individuals you recruited for your studies be sensitive to the people that are coming in. And as this issue about the technician who, just was not careful. I mean, I'm sure all of you have gone through some kind of medical issue or procedure or working with the government trying to get your license renewed or whatever it is you're going through. And that reaction that you have, not maybe treated well or someone disrespected or whatever, comes through. And I think it's important that when you build a team to work with people that are going to be participants in your studies, you build people who are sensitive to the individuals there and know their job and know how they adapt the job to the people that you're talking to and involving. So that's kind of one takeaway. The other one I think struck me is the issue of recognizing the diversity. And one of the things to consider is that when you're recruiting subjects, you're going to be recruiting people with different backgrounds, different ethnic groups, different cultural groups, different historical, perspectives. And it's important to recognize that sometimes language usage, respectful terms, recognizing age, things like this, in terms of how you communicate with people are very important. And sometimes you can turn off a participant if you don't use the same kind of mannerisms that are used in that culture or how they expect to be treated. So that's an important consideration. And I think the last point, I think, is giving back something. You know, I've heard a lot now about how you want to hear about results. And I think it's important to construct that phase of your study in such a way that the communication is always there, whether it's interval communication or end product communication. And also in the way that people will understand and want to hear it. And then the follow-up on that. You know, it's too often, and this goes through what I'm sure all of us have this kind of experience in medical procedures and medical interactions. You're told something, and then you go back home and you think about it, you say, I want more information. And I think this is the case here, too, where you think about what is it that I could do to make people who participated in my study, you know, give them a set of thanks for being there, obviously, but also helping them understand better what they contributed to and what that impact will be on themselves and other people who may benefit from the results of that study. So those are my key takeaways. I'm kind of leave you with that, and hopefully that, and thank you, by the way, for participating in this discussion. It was very helpful. Thank you.
Thank you. Well, with that,
is my secret weapon.
we can see why, right? Let's just end with one final round of applause for our true experts today. Thank you.
My iPad.
I think we're good. All right, guys.
So before we close the conference, we have so I'm going to ask Sigan, Marie-Claude, and Laura Del Hoyo to come back a bit and announce it. Laura.
And Patrick, you don't get out of this.
So it's my great pleasure just to finish this wonderful meeting. Thank you, all of you. And to give a poster prize to Cleona Farrell. I hope she's in the room. Yes. So Cleona Farrell, she works in the team of Frances Weissman at the University College London. And she presented, in fact, 2 posters. And we selected the one on lecanemab binding in postmortem brain tissues from individuals who had autosomal dominant Alzheimer's disease. So, congratulations. And just to say that, of course, all the posters were very good quality, and we, in fact, selected a poster presented by a student or postdoc.
And we do want to thank the T21 Research Society, who is going to fund this prize. So we will be following up with a lovely check that will go along with this award. So wonderful.
So we'll make it very, very brief. I think that we're really proud to have you to have had you these 2 days. I think it's been a wonderful conference. I think that it reflects the wonderful moment that we're in the field. I think that, as we were saying at the beginning, there is great hope for people with Down syndrome and people with autosomal dominant AD mutations. I think that for the first time it is foreseeable to have preventive treatments to prevent the disease. And I think that this is a unique forum to interact and to generate ideas on cross-fertilization. I think it's been very obvious how much we can learn from each other and how many things we can do. And I don't want to extend myself. I do want to say again, big thanks to the Alzheimer's Association for their support, to the Barcelona Alzheimer's Hub for their support. They were the main funders of the conference, to the Jerome Legend Foundation that funded some of the travel awards, to all the companies. I don't know if they could put the sponsors, all the companies that funded this conference, not only for the money they put into the conference, truly, because almost all of them are or are planning to conduct trials in this population. There's the only way that we will achieve our aim, our vision of preventing Alzheimer's disease is through clinical trials. And I think this has to be recognized by all of us. We have to build partnerships, we have to engage with the community, and I think this last session has been amazing in this regard. And the only other announcement I'd like to make is that we had a meeting yesterday with the steering committee. I'm very happy to announce that and the steering committee is composed by Natalia Costa Baena from the Grupo de Neurociencias de Antioquia, Boans, Sigan Harley, Jason Hassenstam, Johannes Levin, Mike Raffy, Laurie Ryan, Natalie Ryan, Heather Snyder, and Erika Tarver. And I think that we all were convinced that this is a conference that needs to be in the calendar, that is important, and we want to continue. So we made the decision to continue annually. So we'll have the conference every year. I'm happy that we will continue the support to collaborate with Alzheimer's Association, with the Barcelona Hub, and hopefully with all our collaborators. And next year we'll still be here in Barcelona. So we keep your attention. We'll confirm the dates, and we hope to have you here next year. And without anything else to add, I'll pass it over to Raquel. I wish you all safe travels. Thank you very much.
I will also be very brief. So it has been an absolute pleasure to have you all here. I want to extend the thank you also to the people in charge of the technical support back in the room over there, and to Rosa and Mireia for support surveys for the organization of this event. Just I wish you a safe trip back home, and see you next year.
There is one coffee, so I mean those have to take place, but those that want to have last coffee, there is coffee and some food down there, so you can get it.